We're going to start in just a minute. If you could take your seats. Why don't we get started, if that's okay? Good morning, everyone. I hope you had a good evening. It's a wonderful dinner last night. Thank you for those who arranged it. I just want to talk through the agenda today. We're going to have an open session now for the first couple of hours. This will be addressed to the draft case studies, and I'm going to talk for a minute or two about the draft, the role of the cases in our charge. We're then going to hear we're calling it a closing keynote by General Corelli. He was to be on the leadership panel yesterday but couldn't make it, but he was in Europe, but he's stopping here on his way back from Europe to share thoughts with us about leadership issues to our benefit. After a break, we'll then go into closed session and we'll begin to work through details of the report that we're going to be writing, and we'll discuss that when we start the closed session. Autumn, is there anything you want to say, just an introduction and stage setting for this session?
The host has the recording feature on.
Okay.
I'll just I'll thank Andre Kapp, who was instrumental in putting these case studies together for us and recruiting the other folks at DoD who helped author these initial drafts so early on in the study process, which is of course very helpful to the committee to be able to have this time then to further discuss them with the other sponsors as well as with DoD and further refine them through our own investigations of the literature. So thank you, Andre, and everybody else who worked with you. And I'd also like to thank all of the other sponsor representatives who are with us today, Dr. Brinsfield, Mr. Dawson, Dr. Yee. Is Dr. Hoyt on the... Christy, is anyone on the line?
There's someone on the phone line. Could you identify yourself?
Okay.
All right.
We'll just
figure it out.
But
okay,
I want to thank you all also for being here today and taking the time to discuss these with the committee. I think it's really excellent to have this additional perspectives here from the civilian side so that we make sure that we're answering the charge that the committee's been given in terms of both the DoD lessons learned and the translation to the civilian sector. It's meant to be a pretty informal discussion.
So to repeat the disclaimer from yesterday for the open session, this is an on-the-record, it's information gathering session, and no one should interpret questions from the committee or anything that's said here as conclusions yet. We're not near conclusions or recommendations. We're going to go over the case studies for 2 hours now in this session. We've been charged specifically in the formal charge to the committee to draw on case studies of common combat-related injuries that are relevant to the civilian sector as a source of evidence to support conclusions and recommendations. We have drafts now, thanks to Andre and his colleagues. These are a starting point for development. I think the cases are going to evolve through the next couple of months as we refine them as a source of a benefit to us. The charge is quite specific about the cases. It says we'll draw upon 3 or 4 case studies centered around common combat-related injuries, also related to civilian sector trauma cases, and highlight opportunities and challenges to establishing and sustaining trauma care learning health system. There's a list of specifications about what should be in a case study, and then a set of what we should be deriving from the case studies. So the purpose of this conversation is to talk about the cases that Andre has shepherded so far, to make some decisions about whether they need to be supplemented, and there'll be more that we'll need to do to flesh out the cases, and then to discuss the path forward for refining the cases. These are the cases from which we should be inducing our understandings of the learning system and how it works and how how it should be improved. So, Andre, do you want to begin and introduce us to your work here? People should have read the cases last night, at least 4 of them, and I'd welcome your comments.
Great. Thank you very much, Dr. Berwick. So I brought up these slides, some of which I presented to you last time I was here, but I changed the title because yesterday's discussion really was a fascinating exploration of policy and history of the program and so forth. I do hope that the cases will allow that conversation to be grounded and accessible to a wider audience than is present in this august body. So I kind of titled these slides Stratosphere to Boots on the Ground. So one moment of indulgence before we dive into the cases. I want to just briefly touch on my own personal case history in this regard. So yesterday we really focused on trauma care and a focus on training surgeons and how the DoD inculcates the lessons learned into our surgical colleagues, which is totally appropriate since we're talking about trauma. However, and we also talked about TCCC and the focus on medics in the emergency room, you know, sort of the continuum of care from point of injury to actually getting to a medical treatment facility. But I deployed to Iraq in a combat support hospital in 2011. We had 2, I say, general surgeons. One really was a general surgeon. The other one was a cardiothoracic surgeon. And we had 1 orthopedic surgeon who had just finished a spine fellowship. And we had lots of other doctors and nurses and technicians. So what was our pre-deployment training? 0. You know, I trained as a hematologist, oncologist, internal medicine, and luckily I had personally had some experience in trauma care and spent some time at Landstuhl during my residency in this SICU and took care of combat casualties, of course, when they came back to Walter Reed. But in terms of specific trauma training for pre-deployment for all the other people who were there besides the surgeons, including the anesthesiologists, there was really nothing. Not a single person in our unit had been trained. So this is a problem, and I think when the committee considers how to institute a way of transmitting these lessons learned, we can't forget about the non-surgeons and their training, because really, you know, with 2 surgeons in this combat support hospital, most of the care delivered to patients actually occurred after the operating room, and they weren't the ones doing it. You know, I was, along with my colleague Matt Borgman, who Phil knows very well, who's a pediatric intensivist, by the way, and we were running the ICU. And ironically enough, we had sort of various operations where Matt was often somewhere else at a different facility, and so I was running the ICU, which is kind of funny. So I also put this in purple because this is a purple problem, not just an Army problem, it's an Air Force and Navy problem as well. So we really have to think about how we prepare non-surgeon providers to take care of trauma patients as they deploy. So thanks for that, for indulging my, my plea to you on that. Now, as far as the case reports goes, so, you know, clearly they're going to be helpful, I think, for grounding the discussion, and pictures tell 1,000 words. So we included a lot of radiographs as they were available. The cases that we put together so far are obviously just rough drafts and represent slightly different approaches to the presentations. We struggled with how much detail to give you in terms of the case itself. I mean, you know, obviously we have a lot more information from the medical record about each of these patients, but I thought we would give you enough to sort of give you a picture of what was going on in these patients without burdening you with pages and pages of detail, although that could be provided if you'd like. The other thing is, in talking with Autumn about this and sort of the iterations we went through in terms of structure, we thought about, well, maybe the interesting part of the story is how did the Army or the military will say, learn from each individual case, and maybe talking about, for example, these Thursday conferences and some of the feedback that went on. Some of that is available, maybe not verbatim, but at least in terms of notes taken during these Thursday calls that you've heard about, and feedback to the field, and information being passed up the chain through that forum. The other aspect of it, too, was to talk about how these types of cases stimulated change. So, for example, in the tourniquet case that you received, I think that was the first one you got, Dr. Craig described how a very commonly applied civilian strategy for EMS of scoop and run, just quick, get them to the surgeon as fast as possible, doesn't always work, especially in combat trauma. So here's a patient who had survivable injuries to the lower extremities, and who exsanguinated in a very short period of time, was wounded in Baghdad, practically outside the gates of the green zone, and nevertheless died because there were no tourniquets applied to his legs. And so that story was told and retold, and everybody started using tourniquets, well, eventually. But that kind of story was the impetus for change. So describing that process of disseminating that information, and how even individual cases were used as teaching tools, is something else we could focus on as well. Certainly some members of the committee here were there, Dr. Holcomb, and Phil, particularly for the pediatric burn case, and can fill in a lot of detail in addition to what we can provide. But I want you to think about all these and help us help you. What more would you like to know? So just to bring us back to the statement of task, as Dr. Burke was saying, we really want to use these cases to characterize the components of the military trauma system. And also, one aspect of the learning health system that we've been talking about, but yesterday's discussion didn't touch on so much, is the research and development piece of this. You did hear a little bit from Dr. Butler about how the Army Institute of Surgical Research was engaged in, for example, product testing. Which of these tourniquets actually work? And that's, really important. But beyond that, we did a lot of other studies trying to optimize resuscitation, evaluating resuscitation fluids, blood products, combinations, et cetera. And all that work ultimately yielded what we currently have in terms of a plan for damage control resuscitation and the care of combat wounded. And so that focus on the research investment, I think, is something that should be woven into those cases, and it's clearly easy to do that. For example, in the dismounted complex blast injury case that you received, there was a whole task force on DCBI that was chaired by then Brigadier General Caravallo, who's now Major General Caravallo. Anyway, he took a very strong interest in that and launched a number of major research projects. And that case also brings together a lot of the CPGs that, some of which had been written at that time, but which were updated and received more scrutiny and were further developed. So in each of these cases, we've listed the applicable CPGs, or at least the ones that we thought were applicable. And another thing that we could provide for you is some sort of a forensic history of the CPGs, if you like, and how they evolved over time. Don't know if that would be of interest to the committee, but that could also be woven into the CPGs. I'm just sort of throwing out ideas that came to me in the course of the discussion yesterday. The other thing to consider, which we talked a lot about yesterday, is how these cases may relate back to the education and training investment by the DoD, and how that can be leveraged for the benefit of the civilian community as well, and vice versa, as we discussed. And then finally, well, translation of benefits to the civilian sector, I think, was clearly a major focus yesterday, and I'm sure will not be lost in the cases. This is sort of the process that we went through. We identified the cases in the JTS database of cases from Thursday morning conferences, and pulled from the medical records in those particular instances. We can certainly do more, as I said, and if more cases of a similar type would be helpful, we can provide those as well. As a matter of fact, regarding the tourniquet case, we identified the need to maybe contrast the rather grim story that we told in that first case with, a nice save after implementation of tourniquets. And Dr. Craig actually did find a good case to illustrate that. I just didn't have sufficient detail to include it in the first draft that you received, so you'll get that in due course. So just to review, the dismounted blast case, I think, really covers just about everything. Not listed on this slide, or for that matter, in the presentation that in the case discussion that you received, is also the impact of the dismounted blast scenario on TBI and facial injuries. Facial injuries in there, but TBI is also a factor in a lot of these cases. There's room for discussion of a number of new research and development initiatives. For example, REBOA, so balloon occlusion of major vessels to control bleeding as sort of an emergency resuscitative procedure. This case pretty much touches everything: damage control, resuscitation, and the list of CPGs at the end of it is extensive. This is the Dr. Craig case of an exsanguinating leg injury that is sort of an isolated injury that killed many soldiers until we had tourniquets deployed, frankly. So it's sort of a relatively simple story, but should you be tempted to conclude that this story is a nice pat, once and done, we got tourniquets out there and we're all set? One of my colleagues deployed to Afghanistan 2 years ago, and while she was there as a brigade surgeon, one of her jobs was to sign the death certificates of every service member killed in Afghanistan during that deployment. And by her count, fully a third of the fatalities occurred due to either late tourniquet application or no tourniquet application when one was indicated, or tourniquet failure, we'll just say, slip during transport or what have you. So training and sustainment of skills is something that could be highlighted in a case like that. So again, if the committee wanted to hear about, for example, an early tourniquet case, as described by Dr. Craig, followed by maybe the sort of nice save story, and then the follow-up long-term of skills sustainment issues. I mean, that's one way we could do this sort of longitudinally with short vignette cases that tell a broader story. Something to consider. The severe TBI case you got last night. This is when you have a chance to read it, it's really quite remarkable. This soldier suffered a devastating injury. Interestingly, I treated a patient with almost exactly the same injury, two of them actually in Iraq, and they, in prior conflicts would have been declared expectant, and that would have been the end of that. And this patient survived to have a pretty good outcome, and when you look at the CT scans, you would not believe it. So a lot has been learned about at least implementation of neurosurgical care, and the need to be quick, maintain blood pressure and oxygenation, and transport rapidly, and intervene aggressively in these patients, and you can get much better outcomes than you would think. not a lot of further research in this area by the DoD. It's not, we have a huge brain injury program, but it focuses mostly on less severe TBI, which is something that perhaps we could discuss as well. A severe versus sort of moderate TBI, and contrast the approaches the DoD has taken with regard to those patients. Pediatric burn case, I think there's a lot to talk about in this case, including the fact that these would be among the most complicated, difficult patients to take care of, here in the United States, in places where you have major children's hospitals and level 1 trauma centers and whatnot. When this patient presented for care, we didn't have appropriate equipment sets. Luckily, there was a pediatric intensivist who's here in the room who was able to assist in the care of this patient, which otherwise probably would not have had the outcome it did. But training requirements, equipment requirements, and then the conundrum of how to deal with host nation patients who may not have a discharge option that we would consider acceptable anywhere else for things like ongoing care. And then finally, to tie in a story that has broad relevance, unfortunately, in our communities here in the United States, we included a Humvee rollover case in which the turret gunner pretty much got crushed by the vehicle. And you see here his CT scan with the discontinuity in the right humerus and all the vasculature in there. Lots of interesting stories in this particular vignette as well. Management of, for example, splenic injury non-operatively, but without necessarily the monitoring course that you would like to ensure stability of that patient. Plus the fact that we have general surgeons managing orthopedic and vascular injuries without necessarily the training and experience, expertise versus familiarity that we were talking about yesterday. And then material challenges and R&D type issues regarding, for example, vascular shunt materials. So that's a sort of separate discussion, I guess. But to bring this back, I mean, we're here in July, meeting number 2. We have several months in which we can do a lot of work with you to provide you more information, either more vignettes if you wanted to sort of stretch out this story over time, or more depth on any one case. I think these are all things we can help you with, but that's the extent of my comments right now. Love to hear back from you all and what you think about how we should proceed.
Thanks, Andre. Before we open it up, a couple things up. When we finish our report, it goes to review committee, and one of the things the review committee does is it makes sure that we did what the statement of tasks said we should do. I've never seen a statement of task as detailed as the one this committee has. I've never had to deal with this level of it. But if I can call your attention to page 2.2 in your book, that's the specification of the way we're supposed to use the cases. I don't really know if we have to adhere to the letter of this, get guidance from staff on this, but if you look at the bottom of that page and the next one, it says the case studies will highlight levels of evidence used to develop military and civilian clinical guidelines, pertinent innovative changes that have been incorporated into the trauma care in each case, processes by which the patient and injury information was collected, stored, reviewed, and analyzed by the JTS, including how the information was used by the JTS's evidence-based improvement process, how collection, storage, review, and analysis of patient injury management information differed from those killed in action versus those wounded in action, the impact that the evidence-supported changes in military trauma care and the Joint Trauma Systems evidence-supported process improvement may have had on survivability, how the results of the military's DHP research investment have been integrated into its JTS, evidence of how these changes may be effectively integrated in military training and doctrine, and how they can be applied in the civilian sector, and time elapsed between compilation and publication of evidence and development of the guidelines. That's pretty specific. Can you help us? Do we have to do all? How should we view this, and should we be working with Andre to get all of that done?
Well, you want to say something first on that?
The only thing that I wanted to say is that we did put in a little bit of language to give us a little bit more flexibility than we might otherwise have, and that's that we'll highlight to the extent possible. We also changed it from each case study to the case studies to give this idea that the collection, right? Do you want to?
The only thing I would add is that we do want to have these cases to kind of supplement the work of the committee, but not necessarily drive everything to the nth detail. So I think they're supposed to be supplemental in understanding how the learning health system works. So I wouldn't be that critical about the literal wording of these things. But I think we need to hear from the sponsors on that if they have a problem with what I just said. I think that what we would like, though, is for the people that are doing these case studies to be very familiar with what we've been asked to do, and to the extent possible to include that information in these case studies. And I think there's a lot missing that could be added by the case study developers that would help in the committee's interpretation of these cases.
So my suggestion, given that guidance from Rick and Autumn, is we'll stay at a little higher level here. The question is, we need to, by the end of our work, have understood as much as we possibly can about how learning happens and how it's used. And the cases, to me, they're just important, helpful input for us to study the process of learning. When we get to the level of detail in this, we'll return to the charge later and say, well, did we cover enough of it to make a difference? So that's how I'm thinking about it. We have sponsors here, and I'd like to invite each of you to make a comment or two on or as you wish, on the cases. And also, by the way, say anything else you want that the committee know from your sponsorship. We have Catherine Brinsfield from Homeland Security, Drew Dawson from NHTSA. David Hoyt, are you on the line? Does anyone know if David's on? Alan Yee, National Association of EMS Physicians, Stephen Mercer, allegedly by teleconference from the National Association of EMTs, and John Osborne from the Trauma Center Association of America. So, Catherine, why don't you lead off? And anything you want to tell us about anything is fine, but also please comment on the cases and their use.
So, first off, thank you for doing the cases. I think they're a great start. There are two or three things that I would say. One is Drew knows that we spent a lot of time trying to translate some of this right before NHTSA led the guidance development with ACS and the collection of evidence for the tourniquet guidelines. I think you're going to lose some of the state and local users of this information if we concentrate on a lot of cases that have a lot of PPE that is not available to states and locals. And so understanding the difference.
PPE?
Personal protective equipment. The equipment that is being worn and protecting against torso injuries in these cases is not available even to law enforcement in state and locals. So understanding that difference and how that will play out is important. The most important thing, though, that I think I'd sort of like to highlight is what we're not talking about is time. And time is a very important element of all this. So my data might be a little bit old, but I believe it's still 30 to 40%, Drew, of the U.S. that cannot get to a level 1 trauma center in 1 hour. Is that about right? Mm-hmm. And ATS publishes this. It's available on the web. So if you start looking at the amount of time it actually takes to get to some of the stabilization type mechanisms you're talking, I'll defer to my military colleagues in the room, but I believe in most of the U.S., or in a large portion of the landmass of the U.S., it actually takes longer to get to definitive trauma care than the military considered it acceptable in Iraq. Is that about right? So if we have to think a lot about how to put these case studies in a way that'll be useful to the civilian sector, I want to make sure we're thinking about the issues, mechanisms, and actions that are necessary to actually keep people alive until they get to a hospital. Because no matter how much you train your surgeons, if they are not alive or if their blood is Kool-Aid, by the time they get to a hospital, they're not going to survive.
Thanks, Catherine. Drew?
Great. Thank you very much for allowing me the opportunity this morning, and thank you very much for preparation of the case studies. I think the case studies can be very informative as we move forward, and I think, like Kathy, I think a couple of things. One is, I think for it to be instructive for the pre-hospital component of the emergency medical services system, it'll be helpful to have a bit more information about what happened prior to the patient's arrival at the medical facility. If we could focus a little bit more on that, so that we could have some lessons learned from that, in addition to what Kathy said. If I can make just a couple of general comments, with your permission, perhaps about generally how this might intersect with the civilian side, if that's okay. As I listened to the comments throughout the day yesterday, it struck me that you may come away from the meeting yesterday thinking that the federal government is totally bereft in terms of any efforts relative to trauma or trauma system development. And while there certainly is a lot that needs to be done, I think one of the challenges that I hope this committee will tackle also is how the efforts learned from the military can also intersect with some of the ongoing efforts that are going on within the nation and within the federal government, because we think that is also really important, so that we try to build upon some of the existing efforts that are kind of emphasizing a systems approach. And just to make you aware of a couple of things, many of which you may be already aware, and we can certainly follow up with staff in terms of additional ones. One of which is the Federal Interagency Committee on Emergency Medical Services, which many of you may have heard about. But as General Robb was talking yesterday about the mission of the Joint Trauma System, he told us that one of the strengths of the Joint Trauma System was the diversity of the service culture that allowed the enterprise to benefit from the unique perspectives and missions of the branches of the uniformed services and the diversity of folks coming together. So like that, the Federal Interagency Committee on Emergency Medical Services statutorily is an opportunity to bring the various cultures of all of the different federal agencies, including DOD, to the table in one place, and the strengths of DHS, HHS, DOT, DOD to the table all in one place to make decisions and to coordinate across the federal interagency. So I think it's important that you just recognize that that is there, as well as there is a National EMS Advisory Council that is established to provide advice and input to the federal government on issues pertaining to particularly the pre-hospital component of emergency medical services. The Federal Interagency Committee on Emergency Medical Services has adopted a strategic plan for the coordination of activities across the federal government, one of which includes enhanced lessons learned from the military into civilian practice, twofold, one of which is the clinical lessons learned, and hence one of the reasons that we were able to help fund this study. Secondly is the transition of the military personnel through better credentialing efforts with state governments into civilian practice, and that's an ongoing effort between us and the National Association of State Emergency Medical Services officials. But likewise, I think it's important that we look at, as we look at data, we look at the coordination between the data efforts and the National Emergency Medical Services Information System, which is one of our ongoing projects. And when I say our, some of these are funded by NHTSA, but when I speak of our, I speak very much of the we of the federal government in terms of DOD, DHS, HHS, and all of the federal agencies. Our administrator reminds us at regular opportunities of the importance of emergency medical services, because in 2003, and he makes us ingrain this number in our brain, 32,719 people were killed in automobile crashes. 32,719 people were killed in automobile crashes, and 2.3 million people were injured in automobile crashes in 2003. And he likes for us to think of each of those people not as numbers, but as people. So, and it's important that, so the efforts of data integrate with the National EMS Information System, and we build systems that build upon that and integrate with that so that trauma and EMS integrate. That we build upon some of the efforts to link state EMS data sets with state trauma data sets, with hospital data sets, and continue to build that linkage. That we support the efforts that are currently underway to revise the trauma field triage guidelines that were begun by CDC and currently now being worked on. That we figure out ways, there's a national model for evidence-based guideline development in emergency medical services that's been approved by FICMS and NEMSAC and is being actively supported by a consortium of folks in the nation. That we figure out ways to take the information from the military and to feed that into that national evidence-based guideline process. And as Carolyn Clancy mentioned yesterday, to maybe figure out ways to streamline that, but to expedite that translation of that information. So right now, you know, frankly, as Carolyn said yesterday, the evidence-based guideline process can be a bit cumbersome, and it takes a while to get done. But if we can figure out ways to make that intersect, I think that's where you can help us. I'm not saying we have the magic answers, but if you can figure out ways to help us intersect the data coming from the military into the national evidence-based guideline process, then that's a way to help build upon the military to civilian interface and help us figure out better ways of getting evidence-based guidelines to the pre-hospital community. As Peter mentioned yesterday, they're currently pilot testing ways of getting evidence-based guidelines to the pre-hospital community. We need to take lessons learned from that, what works, what doesn't work, and build upon that to continue to do that. And we need to continue to take those lessons learned and build them into the scope of practice model as that gets revised for pre-hospital emergency medical services, to build them into the national EMS education standards as those get revised and developed. So I guess what I'm trying to say is this needs to be systematic, that needs to build upon existing efforts, it needs to tie into existing efforts, and the whole thing needs to be really needs to be systematized to the extent possible. I think with respect to the pediatric patients, sort of struck me that, you know, there's an effort just being established now and through the Emergency Medical Services Program and USIS to look at a virtual pediatric trauma center, which seems like that would be a useful thing, and Kathy was involved with that initial project, a useful initial thing to look at. And finally, I think looking at EMS Compass, which is the process that's just now going on in conjunction that we're funding, but it's done in coordination with the other federal agencies to look at performance measures for emergency medical services. And this is done in a very collaborative manner. IHI is strongly involved with the process. But if we're looking at changing the system, and this is really sort of what this is to inculcate a sense of performance measurement into the culture of emergency medical services throughout the nation. And if we're able to be involved with that process, to include trauma performance measures in that from the ground up, and to translate some of the lessons learned from the military into that process as a system, then that helps to gradually steer the ship and change the system. So I think building upon ongoing efforts, it's not saying there shouldn't be new efforts by any means, but building upon ongoing efforts and help to determine ways in which that can happen are also incredibly important. So thank you very much.
Thank you, Drew. Drew, could you take one more second to tell us the Federal Interagency Task Force, you called it, or committee? Give us a window. How often does it meet? How's it staffed? How real is it as a functional group?
You bet. So the Federal Interagency Committee on Emergency Medical Services is established by statute. It has, I think, 9 or 10 federal partners on it. It has one state EMS director on it by statute. It is consists predominantly at a assistant secretary level, such as Kathy, who sits on it. The chairmanship of it rotates between DHS, DOT, and HHS. The committee itself meets generally twice a year in a public meeting. The work of that is carried out by staff who are called the Technical Working Group, who are essentially folks at my level. And there are 4 or 5 committees under FICAMS, and they are charged with carrying out the FICAMS strategic plan under the auspices of FICAMS, and we have very specific charges and a very specific RACI matrix in terms of accountability of carrying out that FICAMS strategic plan. And then we report upward to FICAMS. Kathy?
Can I just add to that in that the Safety Lewis Act, which established FICAMS, which is one of the more cordial and functional interagency committees that I've had the pleasure of sitting on. It doesn't require PPD-1 process or oversight by the White House to get good work done, is not funded. All the work that we do on this committee is out of the regular functions of the departments and agencies.
How does FICAMS relate to Brendan Carr's coordinating council? I'm confused.
Good point. So the way that they coordinate, first of all, many of the agencies that are on FICAMS are health and human service agencies. So the way that we are coordinating is that the Federal Interagency Committee on Emergency Medical Services is predominantly focusing on the pre-hospital component of emergency medical services. The Emergency Care Coordinating Center and the console that Brendan is talking about is predominantly focusing on the in-hospital and hospital component, and then we talk to each other. So the console that the Emergency Care Coordination Console that Brendan, that's in HHS, consists predominantly, although not exclusively, of HHS agencies. And that reaches beyond some of the agencies that we would be able to reach, because a deep drill down within HHS to some of the agencies that we would not be able to reach with FICAMS. FICAMS reaches some of the agencies that would not be able to be reached just with an HHS console. So the two, by the presidential directive that Brendan talked about, which I believe is HSPD 21, the two are intended to be the emergency care enterprise on a nationwide basis and to work together,
Thanks.
if that helps.
Well, good. Before we open it to committee again, Alan, do you want to make any comments? And David, is David Hoyt on the phone? Do we know? No. Okay. Alan, please.
So, I want to applaud the committee and the work on all these, the case studies. They're fascinating. They're great reading. Just two small comments. Could the cases be tweaked a little bit to look at the more phases of care? So every time there's a patient handoff, there's a different phase of care. So we can look at the care of the battleground, i.e. by the soldier, i.e. the bystander for civilian world, the medic, i.e. pre-hospital, the fire and EMS, the emergency department, I forget what level medical state facility that is. Then the trauma center, into more definitive care in the U.S. So this way we can kind of translate it a little easier to U.S. practice, because in the civilian world, I run an EMS system, but I have no control over the emergency department. So by breaking up the phases of care, we can really, for me at least, it would maybe be able to focus on what's important, what I can change. Another topic it was kind of briefed on is the body armor. In the civilian practice, in the civilian world, we don't see victims of injury that have the PPE that the military does. I'm glad to see that we have the burn case. So, but can we extrapolate injuries? Can we at least hypothesize what kind of injuries would we have seen if there was no body armor? And then build policy, build policies, procedures, processes to deal with that. Another thing is, can we look at also, again, hypothesize what would we see in the civilian world? Because the ballistics may be different. We may not be seeing the same firearms that you do in the military. The IEDs may be different. The amount of energy in the IEDs that we may be seeing in the U.S. soil may be a little lower than what you would see.
Excellent.
Well, if I could just, those are all great comments. I will say that we chose these particular cases because, and one of the reasons was because actually there was no real body armor issue in any of them. Now, of course, the reason for that is because enemy tactics were designed around the body armor. So we could certainly, as Kathy sort of suggested, probably didn't hear it, but let's look at host nation casualties who definitely received more injuries to the torso than U.S. casualties. So we could potentially include those. As far as detail on the phases of care and transitions, some cases will have, we may be able to flesh that out and give a deeper dive into some of those. Unfortunately, as you heard perhaps a little bit yesterday, and this may come out in future discussions you have in committee, our pre-hospital data gathering is weak, and we don't have a lot of that detail, which we would love to have. But for example, pre-hospital vital signs and so forth. So to the extent that we can dig that up in individual cases, we certainly can try to do that.
Bill, did you have something you wanted to point out?
Yeah, Andre, Andre, if I could, and to go to the three discussants here, three of your cases are readily translatable, highly marketable, emotional, and would be acceptable by all providers down the chain. And they are the pediatric case, the blunt trauma with vascular injury case, and the last one is the tourniquet case. I would think those three cases respond beautifully with some embellishment, with some editorial, with some framework, with some context to all three of what the discussants are looking for, which is readily available, translatable lessons and data to the civilian agencies that set policy, determine training standards, and affect change at the patient level. Some of the other ones, I just think don't translate. And they may translate medically, but they don't translate emotionally, because some of the work that Dr. Hayter's done, looking at the acceptance of the military to provide certain types of pre-hospital and in-hospital care, the civilian communities say just almost probably emotionally, it doesn't relate. That's on the battlefield and we're different. So I think those three cases are important. The other comment I would make is that in reading these cases, except last night's case, sorry about that, the one case that came last night, what I found is a great opportunity if you change the context of how you present the case. And that is that the case really ought to be, here is the case. Here is how the data was collected. Here's the performance improvement that was done in 3 stages. Urgently, then later, in a little bit more system-wide, and long-term. And the last thing is to combine actions taken and think outside of medically, and encompass what we heard yesterday, that the changes to affect cases, if you look at the change, have to go medically to all the providers, and that then opens up the whole idea of how you change, train, sustain, and on and on. It also has to go to the line, and it has to go to the line command, and it has to go to the line first responder, who is the buddy, who is standing next to the person that didn't get the tourniquet. Where can we train them better? And last, that would allow you to identify the tools you need to do the most important thing, which you ought to add to your cases. Be bold enough to give us the future. 5 years from now, if the people writing these cases were to describe a more optimal system, what would you see? Something like this case was translated immediately to an enhanced network of trauma training centers that were integrated into the civilian community at all levels, and that case was reviewed, etc. How about this one? No cases had an autopsy. What a great future thing. In the future, there was immediate there was feedback within 2 months by the AFIP to assure us that the injuries that we identified and the problems that we saw in the management were the result of the death. And therefore, we're pretty sure, or we're sure, that these were the steps that we outline in these cases were taken. You don't have to tell us, but you've got to link us to something that proves that these cases and what you suppose killed the patients or were wrong, were in fact wrong. I just think if you do that, case, data collection, performance improvement, the rungs of that, followed by the actions taken, and then the future. And you really have to take the future well beyond the medical future. Because we doctors think we control everything. We control minutes of care as opposed to that chain which controls years of care. The last thing I would say to you is, the one thing you can show us that you have are the rehabilitation, and I won't start there, but the re-entry and recovery. I thought it was amazing, the case yesterday, and one of the statistics, and I've been looking for this, and despite me visiting Bethesda and San Antonio, is the number of combat soldiers, sailors, Marines, and airmen that have been rehabilitated with a prosthetic and returned to active duty in a combat billet. That is recovery and re-entry. And in the future, that's really the measure. It's not live or die. And you've got, we don't have data on it, but you've got the idea there, and you can do that for us. So in the future, you could describe that this man who had essentially his arm mangled, by the way, no mention was made of the fact that it was insensate and had no motor function, and his rehabilitation, which you could add to it. And then say this man was rehabilitated and decided to stay, whatever you want to do. But I think it's very, very important to expand these and give us the future and what you see, and be pretty bold about it.
Thanks, Bill.
Thank you.
If I could,
Happily, we have a lot of people want to make comments and suggestions, so we have some time. Let's keep it crisp and try to make our goal this hour is try to help make the cases even more helpful to us to understand learning processes. I'm going to go back to the panelists who put their cards up. So you have the priority here, Kathy and Alan.
I'll be very short. Just in terms of the cases, I agree with almost everything that's been said. Just would caution, yeah, I worked in 2 level 1 trauma centers and saw less than 10 out of like 2,000 gunshot wounds that were high velocity, but I would not pull that out. And just to illustrate, how many of you know where the active shooter incident was last night? Lafayette, right. I just want to, it's gotten so common that it's almost not making headlines anymore. So I just want to point that out, that when you're talking about where we're going in 5 years, I don't want to completely pull that piece out.
Alan, you had one comment.
I don't want to make a comment commending this fourth case, the head injury one we got this morning, because I've been doing emergency medicine for 20 years. If I saw this patient come to the emergency department, I probably would have said, "This is expectant." Get all the the organ donation and really not be aggressive. This kind of highlights that we need to be more aggressive. So if I'm learning after 20 years, we really need to take cases like this, take it down to the line emergency physicians, line trauma surgeons, line neurosurgeons, our residents that we teach, and we need to be more aggressive.
Okay.
This is a prime example.
Thanks. All right, I'm going to try to keep notes on points people are making. Tom, your card was up. Did you get your...
This may be sort of what Bill was saying, but I have to say I'm a little lost here as to what exactly these cases are supposed to be doing and how it is that we have approached them, because I didn't really see in them much of what it says that we're supposed to be doing. And so, I see a lot of doctoring in here. We gave them some blood, we gave them some plasma, we flew them here and we flew them there. But if this is supposed to be telling the story the way Bill suggests, which I always agree with Bill, I don't see levels of evidence. I don't see the innovative changes. I don't see anything about the processes, or not a lot about the processes, and I don't see much about the information. And so it doesn't, I don't see how these cases go back to this learning health system. What I see is 4 or 5 cases, and maybe I'm just missing what's supposed to be happening here, and this is just my ignorance. But I have to say, I don't get it.
So this is why we're having this conversation. These are drafts, and now what would make it more helpful to us to understand the learning processes that are what we're supposed to be inferring from here. Thanks for that point. So let's, Adel, I'll just go down the row here and.
So I was going to make comments on thank you very much. I was going to make comments on two cases. First, picking up where Dr. Scalia was talking about level of evidence. So if we look at the head injury case, the penetrating wound case, so the military has been doing something which I think is fantastic. However, there's not enough good evidence to support it, and that is craniectomy after penetrating injury to the brain or after head injury. Probably the only 2 centers which really do it aggressively in the country is Dr. Scalia's center, that you do it a lot. But when we try to convince other neurosurgeons across the country, people are like, no, we don't want to do it. And now there's this crash trial from Europe which suggests that it doesn't really help. So now all these neurosurgeons don't want to do it. On the other hand, in the military, Joe DeBose has a great study which shows that the risk-adjusted survival, or the risk-adjusted survival in the civilian population is about 7% for this kind of injury versus 24% in the military, and attributes that to this aggressive craniectomy regimen. And so I think that is such an important learning healthcare system thing. It does fly in the face of current evidence in the civilian population. And how do you take that one and make it. John, do you want to make a comment on that? It seemed like,
Yeah, I'm dying.
yeah.
So the civilian studies exclude penetrating brain injury by definition. Every NIH-supported study from the National Institute of Brain Injury, whatever it's called, excludes penetrating brain injury in their exclusion criteria of the study. So saying that the civilian studies have any relevance to this thing, to the military, excludes this mechanism of injury. I mean, it's absolutely insane that the federal government excludes penetrating brain injury from their federally government funded. You guys are all government up there. I'm not government anymore. Anyway, it's crazy, okay? And so it this absence of data for penetrating brain injury. Maybe we should have Congressman Gifford come in, okay? I mean, he won an N of 1. So N of 1, Alan, it's pretty interesting. Congressman Gifford was treated exactly, right? Exactly like a penetrating brain injury on the battlefield. Why? Peter Reed took care of her and whipped her up to the operating room. This has been publicly reported, so this is not PHI. Took her from the ED to the OR and called the neurosurgeon and said, come operate on her. She's on the OR table. And had a hemicraniectomy for a gunshot wound in the head.
This strikes me crucial. The line you're drawing between the case and the learning, or in this case, the
translation, okay, and the translation as well. So the head injured one that came in at 5:30 this morning is exactly and must be, translated and discussed and talked about.
And I think that's where we need to talk about, the level of evidence. And I know in many centers we are doing it in some centers we are doing it for blunt injury as well,
right.
And patients are having good outcomes. But that one study from another country shows no good outcomes. So there is that piece we really need to talk about. And I guess here's where you can insert the level of evidence, how the guidelines make a difference, and so on. I wanted to make a comment on another case, but it seems like you had something else.
Well, and it's just in general, the translation of the wounding agents are different, but the wounds generated are remarkably similar. Okay, so I've taken care of a lot of combat casualties, and now I've taken care of 8 years worth of thousands of civilian casualties. And I'm impressed, and I've shown these guys some pictures as we've been sitting here. Although the wounding agents are different, people get all wrapped up about that. But if you, Phil Spinella, and your civilian thing in St. Louis get hit by a train, your body looks a lot like you got hit by an IED. There's a lot of similarities there. A motorcycle accident hits a guardrail, that's 60 miles or 80 miles an hour. That's really significant injury. Those injuries are very similar. The body armor, the last time we looked at this pretty carefully, the body armor really has only decreased chest injuries, not abdominal injuries. When you compare percentages and try to do this to Vietnam, the abdominal injuries are the same. Only chest and maybe some upper part of the head's been protected, but by the body armor. So the impact of body armor is substantial, but there's still lots of body surface area not covered by body armor that gets injured very, very readily. And the police officers that have their less protective body armor on actually generates a lot of secondary fragments through their body as the rounds go through the Kevlar. And Kathy, I couldn't agree with you more. High velocity rounds, even on the battlefield, and the survivors who live long enough, to come into a facility to get surgery are less common than the hundreds of low velocity fragments that the patients have when they come in. So I'm impressed with how absolutely translatable these messages are from the battlefield, even though the body armor is different and the wounding agents are different. The physiology, the anatomy, the response to shock, the response to brain injury. Your physiology, Don, is no different than his physiology, even though you guys are wearing different uniforms, It's physiology and anatomy. It's no different.
Thanks. So Adel has more to say. Sarah, Phil, Joe.
So I was just going to. My second comment was regarding the. Or let me just make one last comment about the head injury thing. That is so important because in that same study Dr. Schwab mentioned, which is now finally accepted to journal, surgery, and what that shows is that about 70% of civilian trauma directors stated that they do not follow Brain Trauma Foundation guidelines at least 80% of the time. So a big proportion are not being treated, and that's a significant problem. The next case I was going to ask about was the pediatric burn case. In the statement of work, it says the patient, or at least over here, it says should have early renal and pulmonary failure. I didn't explicitly find the renal failure in that kid. Did the
abdominal compartment syndrome from over resuscitation of crystalloid
so
required. They led to renal failure.
I didn't see that. I see the peritoneal tap, but I didn't see the renal failure. Okay. Is there more that could be learned from that case? I mean, it's a short case. It's a very emotional case, especially with the picture. I have a little boy who has similar complexion and stuff, so obviously, thank God I'm not a pediatric doctor. Is there more that could be learned from this case? I mean, it's such a broad, I mean, because it's such a broad, I mean, burns and peds. It seems like there's a lot more that we could be doing here.
So just to reiterate what Dr. Berg was saying, these are, you know, sort of first drafts meant to stimulate this discussion. So yes, definitely. I mean, you know, we could have gone in all sorts of different directions and spent a huge amount of effort constructing a lot of detail, but we're sort of asking you to help us help you, right? Because ultimately, I mean, I'll just put this back out there. This is really the committee's work. These cases are supposed to be woven into your report. So we have access to material in the DODTR and in the medical record and so forth that you do not have access to. And so, and also some of the behind the scenes kind of transition discussions and so forth that you don't have access to. So we can facilitate that. But exactly what structure these cases should have, I mean, is to a large degree your call. The other thing is regarding the sort of civilian translatability or not of some of these cases. I mean, personally, I agree with, you know, what Dr. Holcomb was saying, but I would also point out that we are trying to dissect the military as a learning health system, and how are we going to take care of severe combat casualties the next time around is really kind of our big question. So whether a particular common wounding pattern is not common in the civilian world, I don't think should necessarily be, you know, a showstopper on including such a case.
Sarah.
So a fair bit of what I wanted to say was already said by Bill and Tom. I think that these are really good starting points for this discussion. They tell a medical story, but they don't tell a system story, and that's where I think we need to embellish them. And as part of the system, I would, Bill mentioned that he thought we ought to take them to the point of transition to rehab. I think we ought to also see if we could include some psychosocial information, since that's something that we've been discussing throughout this meeting and the last meeting. But one of the questions that I would like to raise for discussion, and I'm not sure if I have a good idea here or not, but I'll just throw it out there, is that I think that while our task is really written as 3 to 4 cases centered around common combat-related injuries, what we're hearing is that there's another story where you could take these same types of injuries in the civilian sector, and they may be handled differently, and the story is going to look somewhat differently. And since we are really being asked to consider both the military health system and the civilian health system as learning healthcare systems, I'm wondering, and I know this would be a lot of work, but I think it might be very fruitful, if we could take these same cases essentially and make them civilian healthcare system relevant and track not only the medical but the system and how you know, how that might, where the gaps are and where the changes need to be in both the civilian sector and the military sector, and compare them. Because we've already heard, just in relation to traumatic brain injury, that there might be a real difference in how it's handled currently And I think that that would be really edifying to have the two parallel.
You want to comment on that from the staff point of view? Is it?
I actually just wanted to clarify whether you're talking about finding actual medical cases from the civilian sector or just looking at how the system would work on the civilian side if that kind of case came in.
Yeah, I'm going to defer to the other trauma surgeons on this panel, but I would think that probably in your experience, you could easily construct a traumatic brain injury case and say, this is, you know, as Alan was saying, I probably would have handled this expectantly, or this is how it might have gone commonly in the civilian sector, and trace that out.
So the reason that the clarification is important is that the IOM does have rules against what we call vignettes, thank you, where you can't make up a case as kind of a hypothetical. You actually have to have a real case. So it's just a line that I think we need to be cognizant of.
If you take Sarah's idea, we could, say, take a penetrating gunshot wound to the head. Tom could come up with a case, a real case, and draw them in parallel. I wonder if that would be illuminating.
I just want to clarify that I used the term vignette a few times when I was speaking earlier, but just to be completely clear, these are real cases, not made-up cases.
I think there's nothing wrong with taking a real case that has been developed in a military system and talk about how the case would look in the civilian system. So it's a real case, and just what are the differences in observation of our experts on our committee. So that's fair.
And well, let's push it the whole way. What about if, I mean, could we generate some real cases, real civilian cases that are more or less the same injury that Andre's described in the military, and just see how that is handled? Would that be possible and illuminating? I guess that's a question for you guys in the committee.
So, Doug, can I show a couple slides?
Yeah, sure.
To address this specifically?
Can you? You may. Whether you can is up to.
Email it to Christy.
Email it to Christy, and she'll show it. Or,
And
well, set up to do that. Are you done, Sarah?
I just wanted to say, and one of the other reasons that I think that this would be really helpful is not only to show where the gaps are in the civilian sector, but also because I think that part of what I see as our task in this report is to help people understand how an IED injury can really be mimicked by some event in the civilian sector. It's sort of transitioning that disbelief, if you will. So having the cases in parallel, I think, brings home the message that this is it's part of the so what of this report. It's because what happens in the military is not isolated and is relevant in the civilian sector.
You know, I'll just make an editorial comment here. When Drew was running the number there, 37,000, in the military side, we're dealing with hundreds. Very important. I don't mean to gainsay that at all. But the civilian burden is enormous, and that mapping across is crucial. I heard Drew's point.
Do we think that the public at large thinks the military wounds will be very different than civilian injuries, especially since we have mass shooter incidents on a daily basis? I'm not sure, actually. And I mean, I wonder if it's more relevant to keep the same cases and then just talk about how we would learn from them in the civilian world, and talk about how they would have been treated or potentially would have been treated in the civilian world, versus coming up with new cases that would detract from it.
I think they should be. The same.
The injuries are different, the lessons are different, they're not translatable here.
Well, that's part of this learning system, is to teach people that
would be crucial.
It's
yeah.
not true.
All right, let me get this back in order here. Drew, you put your card up. I want to give special rights to the panel because you're not here the whole time.
Well, just on this point about doing the translation of a comparable case to the civilian side, if you were to do that and to kind of map it out about here are the gaps, it seems like you could also then identify, here are the specific opportunities for improvement. Those might be specific opportunities from a system side with respect to federal, state, local, and it kind of forces us all to think about what the system is and identify where the opportunities are for improvement. So as I was talking, it might be, here's some opportunities for improvement in the national EMS education standards, or it might be, here's an opportunity for improvement in state EMS legislation with respect to trauma systems to make it all more uniform, or something like that. So you might be able to map it all out and say, here's the problem, here's the fix. And it could be all kind of logical.
Thank you. Okay, John has something you want to show us. Then let me just make sure I've got everybody. So I see Joe, Ellen, Doug, and Phil. Are the cards up? Let's keep going. So John, do you want to show us something?
This discussion about tourniquets. So that's the old tourniquet. It's gone. This is a guy who had a screwdriver and a belt on his tourniquet from 1993. This is the picture of the patient that died with a couple improvised tourniquets on, died from popliteal artery injury that Frank talked about yesterday, Dr. Butler. That really, this one casualty really spurred a lot of interest in tourniquets. These are improvised tourniquets in a soldier who lived. He had to have the sticks picked up off the ground to use. Okay, this is early in the war in northern Iraq where there are trees. If this guy had been injured in southern Iraq where there are no trees, he'd be dead. So you kind of go through this story of tourniquets and improvising, you know, and you have multi-billion-dollar war machine going to battle where you use a piece of cloth and sticks to put tourniquets on. So the CAT was developed by military medics. It became the standard by 2005. This is a guy I took care of in Baghdad. These tourniquets were put on not by a medic, but by an infantryman. This soldier was awake, alert, talking, had a base deficit that was normal, blood pressure was normal, and heart rate of 80. He was not in shock with this injury because his infantryman partner put those two tourniquets on. Such a huge difference in a relatively short period of time. By the way, what's not said is that the tourniquets got put into theater because of a Baltimore Sun article, not because all the stuff in the military said we should do them. Okay, it was the press that actually spurred the action to happen. John Craig wrote a bunch of papers. And then translation, 2008, this is a guy with a drug deal gone bad, shotgun wound to his knee, gets a hemostatic dressing put on and a tourniquet put on, 2008. So now the wounding looks different, but this one is not that different. This is a guy from about 5 months ago who was had his left arm torn off. That's not debridement, that's torn off by a hay baler. He was sitting with a strained driver in the left rear seat, and a hay baler took off his left arm. Tourniquet put on at the scene and got blood products en route by the helicopter into the trauma center, awake and alert when we finished taking care of him. So these lessons about tourniquets are absolutely translatable.
John, go back to the prior slide was a time sequence, I think, wasn't it? The one
yeah, so this is a time sequence of tourniquets, plasma, also by funding, by philanthropy, hospital funding in Iraq, of kind of translating messages learned. It was a little bit different message that I wanted to show in these slides. I'm happy to, I think you have.
Let me, I'm sorry for leaping in here, but it seems to me, back to Tom's point about why are we doing this, I'm thinking an inversion here, which is, to me, the stories, the cases, they're actually punctuations in this. The story the committee has to tell is this kind of thing, which is first this happened, then this happened, then this happened, or didn't. And here's a case that comes in the middle of this story, and here's how it plays. Phil was telling me about the DCR.
The genesis of the ratio paper.
Actually, let me blindside you all. Would you tell that story now? Because there's a story here about learning, about tourniquets, about DCR, about penetrating wounds of the head, and I think we need to master that story, not just the case. That's what I'm thinking. Let me interrupt the flow and ask Phil if he would just take us to around the fireside and tell us.
It's on. You never told them that loud enough.
So yes, briefly, the story has been in early '04. To resuscitate casualties with severe hemorrhagic shock, we needed to use whole blood to resuscitate them. But because the evidence wasn't there, it was often used as a late salvage therapy. But as with experience and anecdotal evidence, we started to use it earlier and earlier in our resuscitation because we were realizing it was quickly resolving coagulopathy and shock.
So let me interrupt you. So you say because of theory and anecdotal evidence. What's going on there when you say theory and anecdotal? Who knows?
Well,
what
experience. I mean, actually, the military has been using whole blood since World War I to resuscitate patients with hemorrhagic shock. But based upon the past 3-4 decades of changes that have occurred within transfusion medicine, it has gone away, and it's been very difficult to be made available. I mean, it's a whole separate story that we can talk about, the influence of blood banking and economics on what's available to resuscitate patients. I don't think we want to go there at the moment. We can later. But I guess the point is, how do we get to hemostatic resuscitation in DCR and how we kind of just tripped on the data. So we wanted to prioritize using whole blood, but it takes about 20 minutes, a half hour to collect it from nurses, doctors, administrators, et cetera. So we in October wrote a protocol to attempt to give blood products, components in a 1-to-1-to-1 unit ratio until we could have whole blood available.
Cells, plasma.
Red cells, plasma, and then we knew platelets were coming to us in January. So we were we wrote a protocol, October of '04, to give 1-to-1-to-1 until whole blood was available.
Who's we? Who wrote?
Al Beakley, who was here yesterday, myself, Jim Sebesta, Lauren Blackburn, and Jeremy Perkins and Tom Repine, and I'm sure John helped.
From what authority? I mean, where were you sitting?
In the second floor office of Ibn Sina Hospital in Baghdad.
But he has to have
Yes.
an organizational platform to do this. Something was supporting him, no?
We had 5 guys that said, this is bullshit, what we're doing. And we're not doing this anyway anymore. I mean, we realized from anecdotal experience that giving whole blood earlier in the resuscitation was saving lives. And without level 1 evidence, without high quality data, we said, we're not going to do this way anymore. And from that experience with, I said, 1-to-1-to-1, when we all left Baghdad in January or so, we all said to each other, we have different research projects we want to do. I said I wanted to look at recombinant factor VII. Around that same time, John mentioned the Baltimore Sun article also came out saying factor VII may be dangerous. So when I looked at recombinant factor VII, I realized that there was collinearity between plasma use and red cell use. And its effect on mortality. So they teach you in statistics to make a ratio out of those to be able to put both of them in the logistic regression. When we did that, the ratio was very highly associated with survival. And then we said to ourselves, that's interesting. We were doing that on purpose. But it took a statistical method to make us realize that what we were doing actually was associated with improved survival. And I think it spurred this entire interest into giving higher ratios of blood products. Maybe whole blood is a better approach and has spurred an entire industry in improving the efficacy and safety of blood products for patients with hemorrhagic shock. But I think you asked me to say the story because of just how we fell upon the data. It wasn't a prospective idea where we said we're going to give high ratios and then study it in that way. It was just something that we tripped on.
I think what I'm trying to struggle for here as an outsider is what is the learning system? How did this story become, if not doctrine, at least useful in saving hundreds of people?
Well, it was not a formal learning system. This was just motivation and desire and passion to do the right thing for patients, and then the desire to just study it. So it took a Herculean effort for Al Beakley and then someone else, Jeremy Perkins, to collect over 300 variables per patient on close to 3,000 casualties. And Jeremy did this in over a 3-month period. We knew we were on to something big. and we weren't going to let 24 hours in a day get in the way. And we all just dug through charts, mainly Jeremy and Al, but all of us. And from that, it helped spur, I think, the growth of maybe the Joint Trauma Registry. There's a whole blood database that's associated with it, and a lot of the publications that have come from it have come from that effort. I mean, not all, obviously, but some.
All right, sorry to get us off this. So let's go back to the order of people asking questions, and
John, can I make a comment?
Of course, John.
Yeah, sorry. This, I think it's important that this learning system paradigm that we've all kind of fallen into, and Joe, it's a great paradigm, was not what spurred this process. All right? There was nobody talking about a learning machine, a learning paradigm. This was a group of people. This, in Somalia in 1993, we gave fresh whole blood to patients. A third of the hospital donated and went back to work. That's been true since World War I. Every combat situation U.S. forces have been in since World War I have given fresh whole blood, every one of them. What has happened, and then then we set up the Joint Trauma Training Center in Houston and talked about fresh whole blood to people. So you set this framework, you set this ground, if you will, for then fertile, for a group of folks who are taking care of combat casualties and living, eating, and breathing it all day long, every day, and watching them die in their hands and bleed to death, and going back into the mess hall, into the tent, going, we got to do this better. And that's all they're thinking about.
Yeah. Joe, do you want to, I'm sure you want to respond there.
Yeah, I mean, you just described a learning system.
I know, but not, but you know what I mean?
I do.
Nobody used the words, there was no structure, there was no aim on high.
Sure, and you don't need, I mean, everything that I described yesterday is basically it's like a after the fact description of what happens in a system that naturally emerges when people have the right, I mean, it's what Phil just said, they're motivated, they're interested, they want to put the effort in. That, I mean, you basically have described, an engaged, alert, awake human being. Everybody wants to learn when they care about what they're doing. I mean, you do it. In the last 3 days, I've learned how to come from the Hotel Palomar to this place better than I knew 3 days ago. So, yeah, little things. I mean, baby steps. But so what a learning system does is it's about conduciveness. It's just what can we do to make what happened naturally and what happens naturally with devoted caregivers. What can we do to make that? To accelerate that. It's just about accelerants, really. So what I was thinking as I was reading the cases was, and thank you. I mean, that for someone who's not a clinician, I learned a lot. But what I was thinking is, if you use the lens of even 4 or 5 of these dimensions, that grid I showed you yesterday, if you used even 4 or 5 of these dimensions for each of these cases, you could say, from a learning system standpoint, here are gaps. Here are things that would have made it easier for you to access the knowledge you needed, for you to have data you need in a quick way. I'm interested in things like, the time from when we have this kind of breakthrough, this aha moment that you described, to the time that it becomes a part of the care process. Sometimes that can take a week. Sometimes it can take 6 months. In the retelling of these stories, one thing that I often find, and this is field agnostic, is that the difference between a week and 6 months usually isn't viewed as a big deal. So in the research community, well, we figured it out, and at some point this is going to get out there in the field. But what I shared with you yesterday is we know that's not true. Mm-hmm. We know that without a deliberate strategy for dissemination and a deliberate network for spreading it, so the real tragic cases to me are the ones where we know what needs to be done, and they're just in that unlucky 6 months before it becomes a standard of care. So my urgency is around how do we create that learning system that's so much more conducive, that accelerates the learning that much faster. So I think one of the things we could do in the context of the cases is pick out 4 or 5 of these dimensions of the highest functioning learning systems and say, where are the gaps? And probably across the cases, we'll find 3 or 4 common gaps that might lead us to recommendations.
Ellen, you were next.
I was struggling with the same issues of, well, how do we translate the comments we heard initially into a framework for how we do our business? And I reevaluated the tasking relative to the cases, and the keywords that I came up with were assess for common injuries and highlight the challenges and opportunities to establishing a learning system. So if you take all of that and you break it down, I think we need to be simple about it. And I think first is we need to be able to describe based on our deliberations, a trauma care system description in terms of its components, its processes, its roles, its ability to innovate, its methods for documenting, whatever it is, describe the system, the trauma system, because in the end, a learning system has to have an aim, and the aim, in this case, is the trauma care system. And we know that in the military, it varies a little, but it's at least has continuity from point to point. Where in the civilian side, there are stovepipes that sometimes connect well and sometimes don't. So we need to describe that, and we need to evaluate their similarities and differences that will then help us understand how we learn in both of those. And the how we learn is the place where the case studies come in and do what I think Sarah suggested, which is look at the case in the context of how did the military trauma care system increase learning based on the way that they do business, and then how would the civilian side, based on that model of care, learn from that same case or not learn, and then define those gaps. And then the result of that would lead to a whole series of opportunities and challenges in terms of integrating and translating those outcome learning processes into a learning system that would cross both boundaries. If we don't do some logic like that, I don't think we're going to get there. And to me, it's really a structural thing. And I think we just need to decide what that is, throw it on the wall, refine it to the way that we like it, and then use that as the framework for this. Because we could go into the eaches of all of this. We've talked about pre-hospital, we've talked about end-to-end process, we've talked about regulatory issues, we've talked about the actual clinical learning process, how you share, but that's way different than just the whole process, the whole system. And so I think we need to decide what our focus is, define it, and then evaluate things in that context. Because we could either be very high level or very low, very detailed and miss out on a lot. So that's my observation.
Two relative nuances, Dawn. So I'm trained in surgery a long time ago. I'm sitting in the back of the room as I listen to this stuff about tourniquets for the last couple of days. There's a clear trend there. And I got thinking about how we could apply that in civilian care. I was thinking automobile crashes, actually, and I was thinking of the level of training needed for them. Is there a downside to tourniquets? Nobody's talked about any of the risks associated with them at all in the last 2 days.
Yeah. If they're misapplied and misused, of course, but...
And so what level of training does it require? I can imagine what they would be if I had some in my car and let the first passerby in a civilian automobile accident apply tourniquets. I think bad things could happen. Just something to think about, because we didn't talk about the downside. I got a second, though, Don. Again, a nuance. There's this great article published back in 2003 in British Medical Journal. Its title is Parachute Used to Prevent Death and Major Trauma Related to Gravitational Challenge. Systematic Review of Randomized Controlled Trials. Points out that parachutes are widely used to prevent death and major injury after gravitational challenge. Parachute use is associated with adverse effects due to failure of the intervention in iatrogenic injury. Studies of free fall do not show 100% mortality, which means that parachute jumping meets all of the criteria to demand a randomized controlled trial. And of course, it's that great tongue-in-cheek, dry British humor to make a point. It has to do with effect size. Sometimes the effect size is so large that you can see it with the naked eye. And when that happens, you don't need a trial. You can establish causal linkages. The whole reason for trial is to establish linkages between cause and effect. So if I take this intervention, I can predictably get this particular outcome. Internal validity. You were describing a circumstance where you could get it from reading charts, that the necessary information was visible if you went back and reviewed a chart. And sometimes that's the effect size. I spent a big chunk of my life at the Farber running randomized controlled trials, and I guarantee that in those trials, I had to carefully plan the data that I collected to see the effects that we were after. So kind of a hierarchy. The way we would say this in classic improvement work in a learning system is, how do you know if a change is an improvement? And so I just wanted to link it tightly into measurement systems and the idea of kind of levels of detail in measurement. It's a really helpful concept as you think about this, as you structure these things out. So,
Kathy, did you have a point you want to make? And then we'll go to Doug and Phil.
Just again, really short. I think Joe said most of what I would have tried to say much better. But when we started looking at this and we started the work that ended up in the first responder guidance, saving lives or increasing survivability in active shooter and IED, which was just published, and I'll send it to Autumn. I think, one of the first things we did is, instead of just filling the room with medical people, we actually pulled in some people from the military whose whole job was to do rapid cycle protocol development and asked them how they did it. And so, whatever the other system is, systems engineering, spiral development, whatever it is, that there are a lot of places now that do this rapid cycle protocol, rapid cycle change development, and medicine just isn't one of them.
Doug and Phil.
First of all, thanks for the time and effort to find these cases. I am actually somewhat amazed at how over the years you are able to pinpoint and think about very specific cases that may have changed something. It seems like that system for tracking whether they come from the Thursday morning conferences or whatever. And I think you've probably heard this, but I just wanted to make sure I sort of say it more bluntly and make sure everybody agrees, or see if anybody agrees. I think these are a great basis on the clinical side, but when you weave in the additional information, I hope that it gets down to the real nitty-gritty of, the specific cases that were presented at the Thursday morning, or whatever it is on Thursday, M&M. And what was the outcome of that? Was there any directive that went out? Was there any, are there guidelines that changed based on some of these cases? And if so, what was the specific guideline change, and how was it distributed and communicated? I think that would be very helpful in helping us understand the learning system that was involved and how the case became something that wasn't just an M&M that the few people that attended learned something from, but did any of these go further to that sort of thing? And it also strikes me what you said initially about the background of some of the people. If there is even the extent of the background of the education or pre-training that some of the individuals that took care of these patients could be woven into this. What specific training did the field person have, or the first physician that saw them, and if they happen to be a hematologist or oncologist or something, what was their training? I think that kind of detail that helps us really understand who exactly was touching these patients, what helped them be trained better to take care of these individuals, et cetera, might be helpful to weave that detail in.
Two comments. First, I too initially was a bit confused with the case reports and how we were supposed to use them. But I think now it's becoming clear that we need to have a structure, as Bill was mentioning, as well as Ellen. But that formats it somehow with the statement of work or need. But there are still, I think there are 4 main categories as well that have been the main theme of the past day and a half. And that's leadership, specifically with accountability or maintaining compliance to the learning system. And I think we all know without auditing compliance to a learning system, it will never be optimal. Right, but then with that, there's education, training, and research that are all potential gaps in each of these cases. So to layer on top of what Bill mentioned initially, also accountability, leadership, maintaining compliance, education, training, and then research gaps within each of these cases, both military, then how that case the gaps may be different on the civilian side too. I think that would really help us pull out what we need from these cases. The second point I wanted to make was about we have to be careful not to over-rely on evidence-based medicine within the learning system. Clearly it's important, and clearly we need to state when there is and when there isn't evidence. But we got to be careful not to misapply evidence in the civilian world that is very different from the military setting. Because a lot of what we do is bundling of care, right? It's trauma care is a bundle. I mean, John coined the term a DCR, that's one specific bundle, and I don't think it's appropriate to look at a European study on decompressive craniectomies and say there was no evidence there for outcomes, therefore maybe we shouldn't apply it in the civilian world. No, maybe we should be supplying the bundle of care that includes decompressive craniectomy, and the gap is maybe large comparative effectiveness research trials to look at it in the civilian world. Because there's a lot of value to the experience that has amassed over the past 13 years plus, and we can't just throw that away because there's not grade 1 evidence for it. And I know you weren't saying that, but it could be misconstrued.
Jory and Bill.
I just have to comment from a trauma program manager standpoint, and you know, a lot of the things that we're hearing today are things that we would, if these cases were in the trauma center, would be identified through our performance improvement process. So if you look at what makes successful trauma performance improvement process is, first of all, you identify it fairly quickly. The trauma medical director owns a great deal of that, and then it goes through that authority change to make it happen fairly rapidly. And so as we talk about the trauma system and the design, we need to make sure that that level of PI, performance improvement, is truly outlined so people really understand the infrastructure that it takes to be successful. There are lots of PI programs that are out there, but the ones that are really successful have ownership at the medical director and then through the infrastructure of the hospital to be able to make changes happen fairly rapidly. So I just want to make sure that's clear.
Bill, you had a comment?
I just want to make a general comment. I'm sorry. I just want to make a general comment and to pick up on what Dr. James has said, and then a specific comment on perhaps the way I would see the structure ending in each of these cases. So the general comment is that I was watching the body language and the facial expressions when Phil was describing how 5 very motivated people in a room on a 2nd floor had an observation that they had to do better. And it was very interesting to watch John Holcomb go back to 1993 and pick up the Herald case that changed the way that we think about hemorrhage control on the battlefield. What's interesting is that throughout the history of medicine, and especially those that are at that field in medicine, in which they have to react to something they've never seen before, you become instantly pragmatic to save a life. And the essence of medicine is when you've never seen it before and you save the life. And I will have to say, with all humility, that one of the greatest things that's gone on, that has occurred in this war, is the National Training Trauma Centers. And categorically, when I talked to Jeff Bailey when he was at St. Louis, J. Joe Hanningman at Cincinnati, Tom at Baltimore, Demetriadis in Los Angeles, every one of them said to me,
one of the things that happens is those young men that we had in our midst for 4 weeks, now in the battle, would pick up the phone, the cellular communication, and say, what do I do? What do I do? Now, capturing that in a way in these cases is important. So let me go back, Andre, because I think you're hearing that we like the cases now, so you should feel being better. But for example, on the Blunt case, and Andre made a statement that I thought was interesting. He said, gee, a general surgeon had to take care of that because there was no orthopedic surgeon or vascular surgeon. So let's go to the structure and how we learn. A future recommendation or a future observation would be that Roll 2 surgeon had been to the Air Force Trauma Center, the C-STARS unit, was familiar with shunts, but pushed beyond that, immediately went online and through telepresence was guided by an orthopedic surgeon in longitudinal to properly splint, put on an X-fix, and debride the wound. And then that future piece, we go retrospective and say, how did we get there? What did we put in place? What did we recommend to both systems, military and civilian, to make that happen all the time in both our systems? That's what I think is the future piece here.
Phil, you wanted to...
So, Bill, that's a great point. And actually, in pediatrics, we tried that. Kevin Kramer, another PICU doc at Walter Reed, developed a 24/7 pediatric teleconference capability so that anybody in any theater could call any of us 24/7. And it worked well for about 1.5 years. And then something happened where HIPAA type issues were being raised for children from Afghanistan, and it got shut down. So it's been done before. It can be done again. I think with the system, we'll figure out a way to get past these HIPAA issues we talked about yesterday. But
so I couldn't have said, let me just say, Phil, there's some similarities, and I apologize, 30 seconds. There's a series of telepresence, a cardiovascular surgeon leading second-year residents 8 miles away in a large animal, anesthetized, veterinarian present situation through repairing a lacerated ventricle and a beating heart. All 8 of those second-year residents who had never done that, okay, successfully completed that, and that animal was resuscitated and put back into a cage alive. And why that, by the way, that report is actually now 5 years old. Why hasn't that caught on? Why hasn't telepresence? HIPAA. For fear that that would be discoverable as that surgeon is leading somebody that doesn't know how to do something by telepresence. HIPAA. So there's so many similarities. But there, I looked at you down on the spot because here's a recommendation: fix HIPAA.
We're going to have a panel, this Sarah, in the panel that you're going to be doing at the next meeting, we really should be. I'm sorry. Cards are up, but I don't think you really mean it. Is that right? John, you do.
Yeah, I mean it. This discussion of guidelines is interesting, and several people have talked about guideline development. There's professional guideline developers. I think one of the strengths of the learning program is we didn't talk to those guys very much. Because we heard from the VA yesterday, they spend a year doing 4 guidelines. And I think this is what you were talking about with the wrist journal surgery paper. You can be paralyzed by the lack of level 1 data. There's very little level 1 data guiding what we do, and occasionally we ignore the level 1 data that's out there. The guidelines were developed pretty quickly to help facilitate transfer of information across the theater. I'm struck by this guideline development movement that's out there and the way the guidelines were done both in the Tactical Combat Casualty Care group and in the Joint Trauma System group, where they were very pragmatic development and taking the available data, which in a lot of respects is, as Phil's described, is pretty minimal. But it's kind of in an academic environment, it sounds crazy, but it's the best you can do. You work with what you got, but you iterate on it, right? You iterate on it, and you collect the data through the registry and the system, and you make course correction as necessary. And I think that's where the system that was developed around these guidelines, which started, frankly, where the resuscitation guideline first came in. You know, it'd be interesting if you took the Cochrane, there was a Cochrane review of parachutes, right? The Cochrane review would say, we can't support or deny, you know, our support for, recommend or not recommend the use of parachutes when you jump out of an airplane. That would be the Cochrane review in their summary statement.
I'll say, I think there's a sleeper in this charge that you're all talking about, and they call it, the military's used the term focused empiricism. That's a very big idea. That it has to do with the nature in a learning system of the quality of evidence and thought that's used to build innovation. And it's a very different way to think. And I think my own opinion is it underlies a lot of the momentum that we see in the military learning side.
So Donna, with apologies, we first started doing this back in 1991 in Intermountain, as you know. We call them shared baseline protocols. I used to get really excited about having really tight evidence reviews. Best guess, we have evidence level 1, 2, or 3. Level 3 evidence is expert consensus opinion in a formal method. For common practices, about 15 to 25% of the time, on average. Sometimes it's much higher, depends on the specific condition. Very often it's very close to 0. When you're putting together a practice guideline, you face that reality routinely. Anymore, the way that we do it is that we try to get one that's just kind of in the general realm. The second thing you do, once you get it close enough, you blend it into workflow so it doesn't rely on human memory. The next thing you do, you build in a data system. Now there's a way to build the right data system. No recreational data collection. It's way too expensive, way too difficult when you burden your frontline teams with it, but there's a method for it. The way I say it to the clinicians in Intermountain is I say, ladies and gentlemen, I have pretty strong evidence that I can't write a protocol that perfectly fits any patient, with some rare exceptions. And doctor, that's why we have you. It's your job, your specific assignment to vary from protocol based upon individual patient need. That's your job. And then you build in a feedback loop. What you look for explicitly, it turns out to be the finest variance measurement system you could possibly imagine. That's how I got my start, was measuring variance in clinical practice. It's a very efficient variance measurement system, and you examine the variance. You've described it as kind of a case review method or a peer review method. You say, why did you vary? What I have is I have a series of protocols, some very successful ones. Oh, Alan Morris's ARDS protocol, ventilator management of ARDS, probably the finest evidence-based best practice guideline I've seen in my life. 125, a little over 125 changes in its first 4 months use. Sepsis, which gives us a current state of the world sepsis practice, reduced our mortality rates by more than a factor of 2. That was 4 years, but a couple of hundred changes into the protocol through that little feedback loop. The way that Alan Morris said it is he said, for all of these guidelines you see coming out in an academic sense, in published form, none of them are validated. Where's the validation data for them? To show that they actually work. And what you discovered was a very rare exception. It just doesn't exist. Why would you ever believe that those represent best practice? On the basis of the available evidence. And that little mechanism, we've been using it for 20 years very, very effectively. I've got about 100 of them running. The thing that's profound, though, is that every time you start one, doesn't matter how careful you are when you first build it, when that thing hits reality, they're abstract. And when they encounter reality, you see a relatively rapid wholesale rate of change if you build in the feedback loop. You see what I mean? Now, for me, that's part of a learning system. That's making it so that you can learn from your own experience. But how do you validate? How do you know it's working? How do you know if my change was an improvement? Understanding there, what I was really saying when I talked about the British trial, I personally would argue, now this is just a funny happenstance, I'm the guy who designed the first sequential analysis trial ever used in the world. It just happened to be on one of the cancers I was assigned when I was at the Department of Biostatistics at Harvard. I don't believe that randomized controlled trials are the right answers, and the shorthand saying, oh, it's a trial, And if it's not a trial, it doesn't count. And if it is a trial, it does. That's very, very short-sighted thinking. It means you haven't been thoughtful about it. So.
Adel, last comment, and then, Bill, is your card up on purpose? Yeah. Adel, comment, and then I'll make some summary statements, and we'll go to General Corelli.
I like what Brent was saying and your comment about how this is a bigger idea, this focused empiricism. And I think one thing we can definitely kind of talk about is how the learning system finds good things and then may have also stopped us from doing bad things. So good things like damage control, resuscitation, John, you published it and now we all use it. But then factor 7, which was also used a lot, is not now commonly used. And maybe, Phil, you can comment on how the military kind of stopped that train from getting out of control.
The better person would be John. But I think my experience is that actually by using higher ratios of plasma and platelets to red cells and whole blood, the need for factor 7 went away. In addition, there was a lot of politics around it that helped reduce its use, but clinically we found it wasn't necessary. But I also wonder if it was used in a goal-directed way. I still believe either TEG or ROTEM could help us determine who would need recombinant factor 7 and who wouldn't. But that was never explored. We now have a lot of interest in PCCs, prothrombin complex concentrates, that may be a safer way of adding a procoagulant effect to patients that have reduced thrombin formation. Don't know. I mean, again, those studies need to be done in the right patient populations. Not every patient's coagulopathy occurs in the same way, and the time matters too. Early in the coagulopathy is different than later in the coagulopathy. There's endogenous coagulopathy and exogenous, primary, secondary. So it's factor 7 melted away for multiple reasons, but I'm not so sure it's a great example of us stopping something that was bad either.
You had a quick comment, Andre?
Very quick sort of plea to the committee, which is just that I think, Dr. Burke, you made the point that these cases could be thought of as punctuation in a longer discussion. So we had never really thought of the cases as the committee's report, right? I mean, they're not going to tell the whole story of what your analysis of everything you've discussed and heard about is going to be, but we think they will be helpful for illustrating these things. So concrete suggestions, I mean, I've written down as much as I could from today's discussion, but if you have very specific things that you'd like to have the cases touch upon, particularly data gathering wise, those suggestions would be welcome.
Yeah, if I were in your shoes, I'd feel a little bit like, could someone get this in order? And let me just say, I don't think you by any means bear the whole burden here. This is, you're giving us grist, and the committee has responsibility for taking this and making what we need. But and your work has been just superb. I'm so grateful for what you've done so far. So I will, let me make some summary comments of what I think I've heard. I have one weird comment first, though, which is, of all the materials we were sent, Bob Mabry's paper was the one that I just can't get out of my mind. And this story of the 75th Rangers, it's a case, in my view. And it's not a case about a person. It's a case about, it's what Sarah was saying, about a system that absolutely looks like it did something quite remarkable. Is it weird to think about that case as something we should be looking at? Do you want to make a comment?
Yes, sir. Can I use this mic?
Yeah, please.
So I'm Dr. Bob Mabry. I used to be the Director of Trauma Care Delivery for the JTS. I was also the Dean, the Academic Dean at the Combat Medic Schoolhouse. I was a former Special Forces medic. I deployed with Dr. Holcomb to Somalia. Now I'm an ER doctor, and I'm the only subspecialist, boarded subspecialist in pre-hospital care in the DOD right now. So that's my background. So the Rangers are bright spots, and there are other bright spots out there in the literature. We've talked about quite a bit of them over the last couple of days. So there are places where we can look to what's worked as far as the system goes. I think you guys have a significant burden in that you've got maybe 20 or 30 people across the Department of Defense, Dr. Holcomb, Dr. Eastridge, others sitting here at the table, who have really done what we just talked about. They had those conversations, they talked about those tough cases, and they resolved to fix it. So the challenge, I think, going forward is, and so this has been at an organic grassroots level that's bubbled up over time. If you take about 20 individuals and took their work away, things would look a lot different over the past decade or so of war. So the challenge is, how do you build the ship to automatically correct its course? And so the destination is the elimination of preventable battlefield death. I would caution the committee against looking at case fatality rates as a measure, because it's very multifactorial. So that's the destination, elimination of preventable battlefield deaths. How do you build the autopilot in that ship where it automatically detects where it gets off course and gets back on course?
You've given us in your paper, a lot of suggestions about how that might happen, and I'd just like to put that on the table as a case on the maybe the Ranger story is the right one, I don't know, but that was the
Don,
clarity of that goal and the way it was executed and the use of all the available knowledge just stunned me.
Can I
John.
echo your comments? So you had, at the Ranger Regiment, you had a group of medics and a Ranger regimental surgeon who completely embraced tactical combat casualty care, and then you had Colonel McChrystal as a Ranger regimental commander who completely embraced his recommendations from his medic and his docs to implement across the regiment on an equal level with going to the range and shooting medical care. And to my knowledge, there's not a single commander, line commander, who's done that as effectively. That's why. It takes both, and that's why we have leadership and medical care in this committee. And sir, it's hopefully one of the reasons, we can talk about this. But you have to have both of those guys working together.
Sarah, I know you're going to comment on this, and
Yeah, I had the same reaction that you did to the paper, and I feel like the story of the 75th Rangers Regiment ought to be like in the introduction, way up front in our report, because I think that the idea of, because I think we need to build on notable successes, and it's a great example of how even small changes can make a big difference in the system. And if we don't have that kind of story, first of all, it's a very powerful story on many levels, but I think that without having that kind of story up front, it almost seems like a daunting task to sort of, right, but it is achievable. And so I think that story has to be up front.
last word, and we're going to have to transition to General Corelli.
Essentially, I need some help with my rapidly advancing senility. There is a term for what we're describing. The specific case study was malnourished children. And rather than looking at it as a problem and looking at the problem side, they looked for bright spots. And as I recall, the moms who were solving this for their kids, they were poor Asian families, and they were finding things like slugs and snails in the rice paddies, feeding them to their kids. But it has, Jody, you remember this? It has a name. There's a system that was described.
It's in the book Switch.
It's in the book Switch. Yeah, that's right.
Sorry, David was coming in, and you say it again because I know that book well.
Yeah, it's the book Switch, and it was talking about how they found solutions to malnourished children. Was instead of tackling it as a problem, they went to look for successes out across the
bright spotting.
Yeah.
Bright spotting. So is this an example of that, Don?
Yeah, I think so. I'm afraid I want to respect General Corelli's time. He's really stretched to be with us, and I don't want to keep you waiting any longer. Can we transition? But I'm going to take 1 minute to summarize just a little bit for our mutual benefit some of those points that I've heard. This is not meant to be the last word at all, but just some of the things. We've had several comments on the importance of cases addressing pre-hospital care. That's going to be crucial, and we have to attend to that. And then Bill mentioned the other end of the spectrum, which is a case following through a little more thoroughly through the continuity and handoff back to rehab and maybe even psychosocial needs. There's a little more that we need in the cases on transfer of knowledge. This to me is the big it's the big unknown to me. I can hear Phil talk about 5 guys working in a garage and coming up with an idea because nothing will stop them. And I can hear the end of the story on the curves that General Rob showed us. What I don't understand is the middle. I don't get how the 5 guys in a garage coming up with a new way to handle volume replacement.
Wasn't new, actually. Recycled.
Well, recycled. But that became systemic. And that middle part is still elusive to me, and it's part of what people have been asking for an understanding of mapping the case to the learning system, and we're going to have to dig in more to that. To me, the trajectory goes innovation or rediscovery, if Phil wants to be modest about it, or tourniquets, and then there's an expansion piece here where it becomes systemic, and I don't get it. I don't understand how that works. Then it's stabilized, and that's our conversations about training and embedding it in the DNA of the system, and then there's a piece of maintenance and recertification of the knowledge. That to me is the learning sequence we're talking about. In each phase, the stories have elements of each phase. Did you want to comment on that point, Phil?
No, it was leadership. It was John's leadership that took it from idea to implementation and maybe to that graph.
One would
guess.
guess.
Him that got on the mount and gave the sermon over and over again until it became basically doctrine.
But he had line command.
Actually, there was an hour rack that made it close to doctrine.
And in the military side, line command has something to do with this. Maybe General Corelli will comment on that. There's something happens that is able to make it systemic that we need to understand. Another point is Sarah's. The way she said it was, we need not just tell a story of a case. It's the story. It's a system story. And I think that, to me, is the one redesign of the cases that's most important, is to tell a case that's mapped to the story of the system, the learning system. We have the idea from Sarah of developing civilian cases that biologically parallel the military one and say, how does this play out on a civilian side? And that's a new idea. It has staff implications, budget implications. We have to talk about whether we could develop that. There's the bigger issue of tying the case to whatever learning framework we use. We could take Joe's points of a learning system and say, how does this case map to the elements of a learning system? And then I think it was Adel, I don't remember who raised the issue, should we have a case on something that isn't an innovation that spread, but something that got stopped? And he proposed Factor 7. You think that's not quite the story, but we can think about that. Those are some of the takeaways. Will be more refined in reflection after the meeting, but thank you all. It's a great discussion. We are booked to go directly to General Corelli's presentation to us. Are you able to do that? I want to respect your biology and your needs. I think neither he nor I will be insulted if you have to leave the room and come back, but I think we will proceed then, if that's okay. And we'll break at about 10:45 or 10:50 to give you a full amount of time. Yeah. So I'll express my thanks and how honored I feel to have General Pete Corelli with us. General Corelli is the Chief Executive Officer of One Mind. He's a retired general with 40 years of experience. He's the former Vice Chief of Staff of the Army, where he led DoD efforts in post-traumatic stress syndrome, traumatic brain injury, which I think is his current passion, suicide prevention. He was responsible for day-to-day operations of the Army, and that included oversight of a lot of its R&D programs. He was also a commander of the multinational corps in Iraq. He coordinated all 4 military services there. General, thank you so much. And I know you made a very special effort to get here from Europe, I think, and interrupted your travel home. What I hope you can help us think about is anything you want us to think about in context of our charge, but we originally asked you to help us think about leadership, which is what's the nature of a system of leadership that allows the kind of progress in trauma care and learning that we're studying to thrive. But anything you want to share with us is welcome. Please make your comments, and then we'll interview you if that's possible.
Okay. I will limit my comments to about 10 to 15 minutes and then open it up to questions you might have. I take it a lot of you aren't wearing uniforms, but it sounds like a lot of you have had experience, and I did not get the bios of of the committee members before I got here. How many of you served in Iraq or Afghanistan? Okay. Well, I disagree with just about everything you've said in here today, particularly when it comes to tourniquets. I grew up in an army where, when I was a second lieutenant in the United States Army at Fort Knox, Kentucky, it took the first general officer in the chain of command to apply a tourniquet. And that's what the kind of, I was absolutely fearful throughout 20 years of my military career to do it. The tourniquets you showed were all tourniquets that I think were applied by docs and medics at level 1 or level 3 trauma centers. They were not the kind of tourniquets that we outfitted soldiers with beginning in 2003. I really believe it was the soldier and the combat medic that proved the value of the tourniquet. I don't think it was the Baltimore Sun. I think it was the Combat Lifesaver program that, when we first started the war, was a program that we wanted to have one combat lifesaver per platoon in 2001. A platoon is about 30-odd people. And in 2006, when I went over as the Corps commander in charge of 142,000 folks, I was a combat lifesaver. I'd gone through the week's training. I was able to apply a tourniquet properly in 2006 based on what we had learned about it. By 2008, soldiers were going into battle with the tourniquets pre-applied to their arms and their legs. And we ran into issues where some soldiers would tell their buddy, if my leg gets blown off, don't apply that, don't save me, only in that moment that it happened, to reverse his choice and have the tourniquet applied. So I think you need a little bit more of a complete story of this process, and I think it's one that you ought to get into the second and third order effects on, because I don't think it was just medicine. I think medicine was lagging here. I believe it was the application of the tourniquet by a lot of commanders, not just Stan McChrystal, but Dave Petraeus and other people who understood the absolute criticality of not waiting for peer-reviewed journal articles to reach significant mass before you change the way of doing things. Now, I'm going to upset a lot of you in here because I'm a social scientist. I tell everybody I'm taught American government. So to be sitting here in front of the IOM for me is a real honor. But please take everything I say with a grain of salt. But I think basically we have a real problem here. And I think it transfers not only to battlefield medicine, but I think it transfers to the way we do medical research and the way we disseminate medical information throughout the country, which I have a huge problem with, And I'm facing that now as I try to get lessons learned for mild and moderate traumatic brain injury instituted in emergency rooms, and I can't get it done. I just can't get it done. They're just basic stuff. But let me answer the questions I was asked. And the first one was, according to GAO reports and general consensus within the DoD during the last interwar period, widespread trauma care expertise within the DoD withered in the context of the recent MCRMC, and that was a commission that I stood on, congressionally appointed commission, to look at military compensation and retirement modernization. How do you envision that trauma care excellence retained in peacetime? I don't. I think it's impossible. I think it's impossible because of the culture of military medicine and the fact that we cannot seem to get the hierarchy in medicine to understand that their model is insufficient for maintaining trained doctors. I provided a number of slides. I think I'll just really show one here. And this is a slide that really upsets, and it upset me when I first saw it. First of all, I served 2 combat tours in Iraq in 2004, 2005, and all of 2006. I visited every single military hospital. I fought for neurosurgeons when there was only one neurosurgeon in Baghdad. And then we got another one in Balad, and the day I left in 2005, he went home because we didn't have enough neurosurgeons. So we had kids who were wounded on the battlefield, and I know we lost them because we only had one neurosurgeon available at Balad after I left. This is a chart that we put together as part of the commission to take a look at MTF procedures. Like any chart, any statistics, it's misleading in places. But I think if you give it to be 50% correct, it shows you've got a real problem in the peacetime delivery of military medicine today. And that problem is we're basically a birthing agency. That's what we do. And we don't have, and I'm going to speak in terms that probably don't, that we don't have the reps we need to keep our doctors trained to the level they need to be trained to. Now, the Air Force has a different model. The Air Force, because after the Great Revolution of 1947, and the fact that they became a separate service, left with the whole concept of the flight surgeon, and they have no MedCom like we have in the United States Army. And they basically divested themselves of a number of their hospitals to the point that they really don't have very many Air Force hospitals today. Because of that, if you went up the street about 5 blocks, you'd probably find 2 cardiologists at GW who are doing that kind of work, because that's how the Air Force keeps its people trained. They train them with industry, so to speak, with you all. That's a model that's been proposed to try to fix this, but it can't fix this. My other job was head of mobilization, and we have a lot of doctors in the reserve components. I promise you, if you walked up to GW today and said, I'm taking those 2 cardiologists out of here, and they're going to be out of here within 24 hours and sent off to Afghanistan, even in a large medical center like this, there would be ways they could compensate, but it would still be a shock to the system, even though they're up there maintaining their proficiency on civilian population. When you go into Minot, North Dakota, and I pull out the only reserve neurosurgeon that's available in Minot, North Dakota, and send him to Iraq, there's not the same compensation systems that are available. And this is the problem that we have today. Now, the chart is misleading because when you see up there mental conditions is so low, these are all inpatients. And the fact of the matter is we divested ourselves of our inpatient beds, so there's no way that the numbers could be very, very high. We send them all onto the market so they don't stay in the MTFs. And those are the kinds of things I argued about when I saw these charts. But even when you see this chart, you realize you have a huge problem. And basically, the commission came to the conclusion you can't fix this without radically changing the system. And the way you radically change the system is you come up with a series of what we said were EMCs, essential medical capabilities. You change the whole nature of the MTF, not to be a place where all you see is a relatively young, healthy population that has a lot of babies, to attracting other kind of work into that facility, both veterans, not geriatric care. We're not interested in that. That doesn't have a lot of play on the battlefield, okay? But the kind of veterans issues that are overwhelming the VA today, and allow those to come into the MTFs. There was a model for this. It's in San Antonio. San Antonio is a level 1 trauma center. They are part of the fabric of the community. And if there's an accident on I-35, those cases are brought to San Antonio. We felt that in order to do this, we needed to change the entire system. And I won't get into that in a heck of a lot of detail, but I will tell you, because of the culture of military medicine, it's going nowhere. We are going to repeat the same mistakes we've made before. We're going to think our doctors are trained. They're not going to be trained, and you just got to pray your son or daughter or granddaughter is not the first casualty of the next war. Pray they come in at about the year 5 mark, because by then, the kinds of things. Now, I'm being overly critical here, but I will tell you there was no one who had greater confidence in this system than I did after serving for as long as I did. But when I really sat down and looked at it, I realized there was a great variance in our ability to care from the first year of the war to the last year of the war. Please, it's okay. I fly on too many airplanes. The commission tried to change that when it got up to the hierarchy. Basically, it's culturally impossible to change that. Now, the next question I was asked to comment on the role of DHA. DHA is going to do nothing to solve this problem. DHA was a perfect example of bureaucracy at work. We cut the baby in half. Most of us believed, at least the Army did, at least certain people in the Army believed, that we needed to go to a unified medical command. We needed to quit this craziness of having 3 services, as inefficient as it is, and come up with a system that would maintain the culture of the services, understanding each one of them is a little bit different, but at the same time, having a unified medical command that would attack some of these problems here. Have a 4-star that would sit in the tank and make the arguments that need to be made to ensure that our doctors do get the reps that they need so that they're trained and can take care of the person at the next ward. That's not what the DHA is going to do, in my opinion. The DHA is going to try to be more efficient in contracting, but it's not going to get to the issues that are going to maintain the kind of learning system that you want. And what do you see as the role of leadership in creating and supporting a learning system for trauma and care delivery? I think it's just about everything. And I think it's not just the leadership of medicine. I think it's the leadership of all of us. I think it's this combined team. I think it's really kind of taking a look at the way we do things and doing them much, much differently. Much, much differently than we are today. I'm a big believer in open science. I find it appalling the way the system works today. I find it appalling that in the area of traumatic brain injury, which you talked about, the United States Army spent $1.3 billion in research since 2007, and we haven't made any more progress than we have today. We still use Glasgow coma. We still use DSM-5 for post-traumatic stress. Those soldiers that you saw with legs shot off, and I know you're all trauma surgeons, or at least I think you're all trauma surgeons, so you come from a different, I think I understand your cultures a little bit too. The fact of the matter is, I think that the research and the study that's needed in traumatic brain injury and post-traumatic stress has been handicapped because you're all trauma surgeons. And the fact of the matter is, many of the people that have their legs blown off and you save are going to live lives that could be much better if we had focused our efforts to move further along in the injuries that are the most prolific of these wars, and that's traumatic brain injury and post-traumatic stress. And we just haven't moved far enough. And I really believe it is because we have not embraced a system of open science where we share data, we collaborate together, we don't let journal articles and the publication of journal articles get in the way of advancing the science and helping these brave young men and women, all volunteers, to recover from what can be a very, very debilitating injuries that they have. I'm going to stop there and open it up to you. I can get into as much detail of what we recommended that DoD do when it comes to changing the system to try to ensure that we had more reps. A lot of it is built upon the fact that when you're in a hierarchical system, you need the kind of people that can advocate your position. One of the things that we recommended that was, again, our kind of cutting the baby in half was a Joint Readiness Command to take a look at readiness and be that 4-star that could go into the tank and make the necessary arguments to get our doctors trained. That died the minute we published our report, and the rest of what we tried to do has also received no traction. Although we have received traction on a lot of our recommendations, the culture of medicine is pretty hard to crack. And with that, I'll stop and open it up to you.
While other committee members formulate the question, General Kelly, let me take the prerogative. At your opening remarks, you expressed great frustration at your ability to get new knowledge in the civilian sector into hospitals. Can you explain what you mean and what it is you're trying to do and where the obstacles have been?
Yeah, when you take a look at mild and moderate traumatic brain injury, the two places to have, and I'll just speak to those, and I know this isn't about traumatic brain injury, but I'd like to talk about, just because that's where I'm working right now, and I'll explain to you. Really, the two safest places to have head trauma are an NFL football field, and receive informed medical follow-up are an NFL football field and combat. In 2006, when I became Vice Chief of Staff in 2008, Jim Amos and I got together with our docs and said, we've got a huge problem. 100% of the people that are evacuated to the rear, back to the States, that have traumatic brain injury, never return to the fight. We are finding a large proportion of them are medically discharged from the service. We've got to do something about it. We got our docs together. We went through a process that was a learning experience for me. in coming up with a protocol that said, this is what we're going to do. Because we had to stop the kid that went out on Tuesday, got blown up, had listened to his football coach, shook his head and said, put me back in the game, coach, went out on Thursday and got blown up the second time. They were evacuated to Landstuhl, forgot the second explosion, came back home, and most of them medically discharged from the service. So we put in place, we sat down and pulled in a number of experts. And I couldn't do it with our military docs. Our military docs really didn't have too much interest in mild traumatic brain injury. They were concerned about other things. I got a panel of experts in, and we came up with a protocol. And the protocol simply said was anybody in a vehicle that has any kind of damage to it, anybody who's outside a vehicle within 50 meters of an explosion, anybody who's in a building when an explosion takes place, anybody who loses consciousness, or anybody who's command directed will be evaluated using a cognitive test that we had for traumatic brain injury. And if, in fact, they pass that test, they'll still be held out of the fight for 24 hours and evaluated 24 hours later. If they failed either of those two tests, they were moved to a concussion recovery center. We beat the NFL in that by about a year and a half. The NFL, as you well know, and I hope you've kind of followed up, I'm not like most people. I have great respect for Roger Goodell because I think he is trying to change a culture like no other culture. And there's a whole bunch of complicating reasons, but the fact of the matter is the NFL has made great strides, number one, in attempting to try to limit concussions, if that's possible in football, but even greater strides in ensuring that individuals who suffer head trauma are properly evaluated and not allowed to return to work, even though they want to return to work, until they've gone through a protocol. My frustration is we've been trying to take that and get that applied into the emergency rooms. Many of the studies that have been done show that 52% of the people who end up in emergency rooms with traumatic brain injury, mild and moderate, who suffer severe cognitive issues later on, even though they're CT negative, okay, are released without any instructions for any follow-up whatsoever. There's a whole bunch of reasons for that. Some docs have told me that's the easiest thing to clear out of the emergency room when you got people bleeding and throwing up and having other problems. The person who I really can't do anything for is the quickest one to move out. But what we've been trying to do is to get the community together to come up with a protocol that requires that people be properly screened for head trauma and at least given some kind of instructions for follow-up should they experience any of the symptoms that sometimes take place after 24 to 48 to 36 hours. And it's come to a complete stop because of disagreement over, basics of that protocol that, quite frankly, seem to me should be very, very easy to say that we have nothing there today. I really appreciated the comment that our protocol that we put in place was changed over time based on the experience that we had. But to let the pursuit of the perfect get in the way of getting something into emergency rooms so we don't have this large portion of the population that's sent home that has huge issues, cognitive and other kinds of issues associated with mild and moderate traumatic brain injury that's non-CT positive, to me is just really a shame, particularly in today's world. And my frustration is trying to get that done. My frustration is hearing about the requirement for peer-reviewed journal articles before we do anything. When Nature publishes a piece the other day that says less than 20% of that which they have published, the data research can't be replicated. It can't be replicated. And I appreciated the comments of 4 people getting together in the dining facility and saying, what we're doing doesn't work. We're not going to wait. We are going to try something else so I don't have to write those letters home. And as the guy who wrote the letters home, 169 of them in my first tour and 492 in my second tour, we have just got to get better at disseminating medical information and not waiting for the perfect to get in the way of something that is going to increase our ability to help people, particularly on the battlefield. And quite frankly, I believe in everyday life.
Thank you. Floor is open, committee. Any questions for General Crowley?
I can tell it's gone over like a lead balloon.
We're fine. Ellen, go ahead.
It's hard to ask questions after that incredible and passionate talk. And I just as an aside, I mean, I agree 100% with you about your remarks about mild traumatic brain injury and PTSD. But I have a more mundane question, and that is, why did the model in San Antonio work as a level 1 trauma center, a civilian trauma center together with an MTF? And what are the barriers, and can it be replicated?
Yeah, that's a tough one for me as a non-doc to answer, but here's what I think. Number one, I think there's a whole bunch of things that are right in San Antonio. First of all, it's a major metropolitan area. It's not Fort Riley, Kansas. So what they saw was, and what we saw during the war, and it was hard for me to understand too, is we lost a lot of our population to the TRICARE network that we normally saw in our hospitals. We lost a large portion of that population to the TRICARE network. We had to because our doctors were deployed. I had huge problems, and I couldn't get my doctors to admit it because all my docs were graded on the fact of how much of the catchment area, how many of the people did they see in their MTFs. That was the grading system they had. So every time they sent somebody in the TRICARE network, and Ellen Embry went crazy because the bill went up, okay? Every time that happened, the doc was, even though he didn't have the docs to take care of somebody, he was penalized. He was looked upon as not a very good administrator because he couldn't take care of his population without causing this huge amount of money, all this fixed infrastructure, docs and everything, he was sending them onto the TRICARE network. San Antonio lost that and realized that they had to gain it back. They're located in a major metropolitan area. They were able to open it up as a level 1 trauma center to attract back in the cases. They don't have near enough cases, quite frankly, to meet civilian standards. I said I wasn't going to use this word because I disagree with it so much, RVU. But, even though we don't have to be graded on the RVU, we have to go up to Congress and make our arguments for what we have based on RVUs, which I find to be just crazy. But San Antonio had the pieces to be able to do that, and some enlightened leadership that got an early jump on it and has attracted back more than any of our other hospitals and integrated itself into the community, willing to see people and build people who are not in the military at that hospital at Brooke, and have done really an amazing job from what we at MRMC saw when we visited there compared to the other locations we went to, which have not been able to do that. And for some of them, it's impossible. You are not going to be able to get the kind of reps you need in Fort Riley by opening it up to the civilian population. You're going to have to draw upon something else. And one of the charts that I provided in here shows that even from a DHA perspective, the number of hospitals that have to be shut down or recommended for shutdown in the military system is huge. And it really saddens me that I can't get the medical leadership to realize and understand the absolute criticality of doing something different. Now, with the Army's announcement to go to 450,000 the other day, that even exacerbates the problem. Even we have an infrastructure that's set up to take care of about 770,000 people, and it doesn't do a good job on combat medical care on the front end because of this is the population that we see. Yet we're not making, in my opinion, the changes necessary to get us up to standard.
Thank you. Marco, you?
General, it's an honor to listen and be part of the committee to listen to your remarks. Just back from Afghanistan, June last year, had an opportunity to think about how battlefield care occurs and some of the shortfalls we currently have. So it's interesting to hear your remarks around where we, this committee, are really trying to focus in on how do we make some recommendations that potentially can create some change. And then we're struggling with that, I think. You mentioned around line leadership, and I just want to...
I would really recommend you take a look at our report and read our report on the military medical healthcare system. Don't ask somebody in the military to tell you what it says, because there's all kinds of stories going out of what it says that's not true. Just really read what we wrote there, and I think you'll see the imperative that we've got to change things.
It's in our materials, and we all have it.
Fantastic.
So my question is, going downrange, and here we are in 2014 last year, I was asked to go and look at how the battlefield currently delivers things like TCCC. And I recognize on fairly short order and following leaders like John Holcomb, Bob Mabry, and others, that we actually, so in full transparency, I'm an ER doc, so recognize that initial piece of care. And I recognize that actually, as a result of, this was my interpretation now, some line leaders not appreciating the ability to deliver that care appropriately. There's not a logistical chain that supports that delivery of that care. There's not the training and education to a standard that actually allows the execution of that paratrooper, that soldier to execute and deliver that care appropriately. Then there's not a system in place to actually support that from retraining. And that was done as I did a circulation of the battlefield and documented by Dr. Frank Butler and others. So from a medical establishment standpoint, we are frustrated just as you are, because we recognize what the deficit is, and we realize that it is not being executed. And the problem that I'm facing is, you just described, you said line leadership has actually embraced this, where we are saying that then there's a disconnect, because the medical establishment is saying, if line leadership only took ownership of this issue, logistics would be fixed, training and education would be fixed, the system would be fixed because the line owns it. And medical is just the consultant to the line command. So appreciating your frustration, appreciating the frustration of the medical perspective, how do we marry that up? How do we synergize that so that a recommendation so that the DOD can act on?
First of all, I think you have to understand there are good leaders and bad leaders. And there's many in the line who do embrace it and do want to fix it. And I'm sure that there's some that, for whatever reasons, are not doing what they're supposed to be doing. But I think there's second and third order effects here you've got to understand. One of the second and third order effects that is handicapping us significantly in Afghanistan today is a force cap. And for those of you who don't know, we're fighting these wars with force caps. Basically, President Obama announced here not too long ago there's going to be 9,800 soldiers in Afghanistan at the end of the year. Why do you say 9,800? Because all the TV commentators would say there's going to be below 10,000. And when you do that, commanders are faced, and you don't take anything off their plate, commanders are faced with making decisions of who's going to be over there and who's not going to be over there. That is one of the primary reasons why the commission recommended a sitting four-star who could go into a tank and make the argument that you can't handle this cut in the same way you would handle contracting out for aviation maintenance rather than sending your trained aviation maintenance folks over there. Do you understand what I'm saying? Literally remain in force caps. We have trained people in the United States military who can fix our helicopters. We leave them at home. We contract that out because contractors don't count in the force cap. Mm-hmm. And the kind of second and third order effect that you're seeing on the battlefield, I'd be really interested to know how quickly were we maintaining the golden hours, the standard for battlefield evacuation when you went over to Afghanistan here recently?
Yes, sir. That time hack is still in place.
Good. You know, and that was one of the most frustrating things that I had when I sat up working for Bob Gates. We were in Afghanistan because of the tyranny of the geography. We weren't able to maintain battlefield evacuation. It was just barely under 2 hours. And I told Secretary Gates, if there is one thing that has been an absolute certainty in all my training since 1972, is the golden hour. Now, whether or not that applies anymore or not, I don't know. But the fact of the matter is, when you train a force to believe that it makes a difference, you can't just automatically go to 2 hours because you've made the decision as doctors, as I saw occur on the Joint Staff, that you're going to go to a 2-hour standard because 1 hour no longer applies. And I went to Secretary Gates and I said, you've got to fix this. I was lucky. I was in a position to do that. Had I not done that, we would have gone to 2 hours. We would have gone to 2 hours. But that was basically a resourcing problem. The Army had run out of rotary wing aircraft, with the fight in Iraq and the fight in Afghanistan, and because of the tyranny of the geography in Afghanistan, to maintain a 2-hour standard. And what it required was going to the Air Force and the Navy and other places to get additional helicopters so we could maintain that standard, and that's exactly what Secretary Gates did. But we need that kind of oversight that causes, I believe, a majority of the problems that you're talking about today. I can't fix that leadership problem. That's got to be fixed by commanders who don't allow that kind of leadership and understand the absolute criticality of what you bring to the battlefield and what you do for a fighting force. You know, I care about soldiers. I also care about completing my mission, and I know if I'm providing them the kind of combat casualty care that they expect on the battlefield, every single one of them is going to be so much more a soldier that's able to accomplish their mission than they would be if I did not.
Thanks. We have 10 minutes left in this segment, so try to be brief. John, you're next.
Yes, again, General, thank you for being with us. You made such an enormous difference in increasing the awareness of TBI and post-traumatic stress in the line. It made a powerful impact. I think the question we're asking about the leadership in the DoD as far as training medical force and executing their mission, not only what are the characteristics of the leaders we need, but who in the hierarchical structure, where should the responsible party sit? Should there be a single responsible party for the medical delivery of care, for combat casualty care, and where should they sit? I worry about accountability.
I think it should serve with that 4-star that is the Joint Medical Commander. I think we need Joint Medical Command more than we need anything else. We can't let the 3 service 3 stars. And the problem with DHA is you've just added another 3-star to the mix. You know, get 3 3-stars together in a room and you're going to get 3 separate answers based on the culture and where they come from. I had an advantage. I mean, your system is daunting. Who's going to argue with you? You know how hard it is for me to come in here as a guy who taught American government at the United States Military Academy to walk in these doors and talk to the Institute of Medicine and think that anything I'm saying is going to have any kind of relevance? I mean, you can throw terms and, you know, this study and that study against me and blow me right out of the water. And the problem we've got in the building today is no one stays as the Vice Chief of Staff for 4 years. I was like that the first year. My doc would walk in here and he looked at me and he said, listen, that traumatic brain injury, a bunch of baloney. I used to play rugby when I was a kid, and I had 6 concussions, and I'm fine. Look at me, I'm a surgeon. That's the advice I got. That's the advice I got. I said, well, he must be right. He's a doctor, for criminy sakes. He's a surgeon of the United States Army. How can I question what he is saying? And finally, I said, I'm gonna start questioning it. And I started questioning it when I went and said, tell me really what is post-traumatic stress? And I went to 4 doctors and they told me something different. And if you want proof of that, see what happened at Fort Lewis, Washington. You had a professional disagreement between forensic psychiatrists and the rest of psychiatry, and a whole hospital chain of command got fired. And it didn't come out in the paper that the forensic psychiatrist at Fort Lewis, Washington, changed more. You understand post-traumatic stress? We've got ourselves in a conundrum here. You know, Congress got so frustrated in 2007, they put in the NDAA that anybody who has a VA diagnosis of post-traumatic stress gets 50% disability. And because of that, all soldiers are good soldiers, but I promise you, when you're asked to leave after 12 years, when you thought you were going to make it a career, and you're going through your physical to get out of the Army, it's pretty easy to go online and find out how you need to answer the 20 questions in DSM-5 to get a diagnosis of post-traumatic stress. Pretty darn easy. And my point is that we need more people inside the building questioning the docs and making sure that we're not just getting, you know, there's a lot of disagreement in this room in here today on many of these things. We need people to make decisions, informed decisions. I believe that it's just not in the medical community, and that's what scares me about this. I really believe that this is one that just became so hard that the docs basically said to the senior leadership, listen, you can't do this because of blah, blah, blah. And the senior leadership not wanting to go ahead and challenge those docs is basically caved in and doesn't realize that this is a huge, huge problem that can't be fixed by the kind of Band-Aids that people are saying are going to fix it. Thanks. I really think you need a 4-star. Somebody can then go into the tank and make the arguments and say point blank. And I know that's foreign to your system, but that's the way a hierarchical system works. And you've got to have parity at that level to make that argument. I can't imagine why the docs didn't realize it would have been a hell of a great thing to have a 4-star doc.
Thanks. I'm sensitive. We have 4 or 5 cards up, so keep your questions short. And
I'll try to keep my answers short.
Thank you so much, General.
I'm sorry.
Bill, go ahead.
Thanks, General. Not to have any recognition, but I think if you would have asked how many served in the military during combat and included Vietnam, you would have seen a few more
I meant to say that, and I apologize.
I only bring that up to say that I agree with you. I think we are going to lose readiness. We've already lost readiness, and I'll give you an example. When I finished my training in the United States Navy as a general surgical resident in 1977, there were 205 active duty general surgeons. 2 years later, there was under 100, and half of those had never seen combat. And that's a precipitous decline, and it's probably why we fell into such a state of affairs. Also, I think what you're calling for is truly an entire paradigm shift at how we approach medical readiness. We've done that once before in the military, and the long fight and finally the establishment of Special Operations Command. And I think what all 300 pages of your report I didn't read, but I read the medical section over and over and over, and I'm very interested if that was discussed. Carve medical readiness out and sell it to everybody as the line, as we want Special Operations Command medical. And they are charged with and responsible for delivering the life-saving trauma and combat casualty care on the battlefield. Has that been discussed? And if not, would that be something that you would be looking for as coming out of the recommendations that we have to make?
Yes, 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 yes. Remember the name of our commission, Military Compensation Retirement Modernization Commission. We went about as far as we could, and a lot of folks thought we really outstepped our charter by saying we wanted to have a readiness command. We went with readiness command because we felt that every one of our recommendations was going to impact on readiness, but we really felt in the medical area that it was going to. And the example that I used and told everybody was, you know, and we found this in our report, it has been written that all dependents have the ability to get dental care on an as-available basis. And that was written after we downsized the number of dentists we had, only to take care. If you took that statement home and tell my wife that, she will just laugh in your face. You know, my dependents, except when they were in Europe, never were able to get dental care because the military, like any other business, downsized its dentistry only to take care of its active component force. The danger of our report was that you could see that occurring in medicine in the same way if you didn't have somebody to make that argument. The kind of thing that you are talking about, the embracing of this, was we felt the purview of that 4-star and the supporting staff that they would have, and to be able to go into the tank with the other chiefs and the chairman of the Joint Chiefs of Staff and make the argument that you can't take Medicare copays down to 20% or TRICARE copays to 20% below Medicare and expect to get docs to be seeing your people on the TRICARE network. That was another thing that occurred over time because of the budget battles. And it goes back to your question. So much of what we see are second and third order effects from fights that have nothing to do with medicine. They've got everything to do with budgets and force caps and other things. But yes, I think what is impeding that happening today is you don't have that 4-star who can argue in the same way that a COCOM commander can make an argument for his medical infrastructure.
Just to follow up, General. Just to follow up, sir. But could that argument be made outside of the medical hierarchy? And is it the line that says, we want the 4-star to assure readiness for our troops?
I would hope you would. That's probably within your charter if you believe that's something that's needed. I think it's absolutely essential if we're going to fix this system.
Thank you.
I mean, you've all gone to, I mean, by maintaining 3 separate systems inside a force that's successively shrinking, we're fighting everything that's happening in the administration of medicine today, are we not? I mean, aren't you creating places like Partners in order to find the kind of efficiencies and make sure that you're using your resources in the way that they needed to be used, that you've got the right docs to go to battle? I mean, the only reason why we have this system, quite frankly, it's got nothing to do with taking care of people in peacetime. It's got everything to do with picking up docs and moving them onto a battlefield and taking care of soldiers like have problems like the pictures you saw up there. And I really believe it's going to take a change in the hierarchy. And a realization that we've got to do something different. We cannot be wed to the MTFs under the old model. It just is not sustainable to maintain the kind of trained docs that we need to have.
John, we have 3 people left, John, Edel, and Ellen.
Sir, thanks for your time today. Colonel McCosey and I were talking yesterday, and we agree completely about the 4-star Medical Corps Unified Medical Command as solving a lot of the problems. You can't have a third 4-star discussing with 3 other 3-stars. It's just not the way the military works.
It doesn't. And for those of you who don't understand, I'm sorry, but that's
it's you know, whoever created that was frankly stupid and ignorant of the military system, sir. You know, your frustration, I think, at your level as a 4-star is replicated by the frustration of many of the non-general officers in the medical corps. And my question for you is, the medical corps general officers, with some exceptions, are reluctant to make decisions, and yet still get promoted. Why is that? And how does that culture get changed? To me, it's a core question of the lack of decision and initiative in the medical corps.
I really don't know how to answer that question. I would hope that we would see changes. I would hope that we would see people who are willing to look at this problem and not say it's going to go away. But I think you have this horrible cultural tug and pull of the culture of the departments. I mean, you know, if I was the de facto mayor of Baghdad for 1 year in 2004 and 2005, that was easy compared to pulling together the cultures of the Navy and the Army at Walter Reed National Medical Center at Bethesda. You want to talk about hard. That's the hardest thing I've ever done. And I literally, it was amazing to me to see that whole process. I'm really depressed right now, and I share a lot of your depression because I think faced with the facts that somebody would look at this system and say that it is not going to take care of these young men and women, all volunteers who are going to deploy to the next war. And I don't believe the Band-Aids that are being designed can come even close to providing the kind of training that's necessary to ensure that our docs can provide that kind of care. I'm disgusted that we are not, at the leadership level, talking more to our line leaders about the absolute criticality of becoming involved in this process to ensure that they have got the best team to take care of their soldiers in the next war. Soldiers, sailors, airmen, and Marines.
Sir, this table's replicated from 1990. It's exactly the same in 1990. It's in the GAO reports, all that stuff that was.
Oh yeah.
This hasn't changed in the military in many, many years, and yet has been allowed by, and I would say both by the medical leadership and then, you know, who work for, as you know, non-medical commanders, allowed to exist. Identified, talked about, presented, published ad nauseum.
I mean, this was an amazing one to me. 50% of the median is less than the 20th percentile of industry workload levels. For example, 31% of the median for emergency medicine in the national capital area is less than the 15th percentile of emergency medicine workload.
Adam?
Sir, thank you for your comments. Unlike many people at this table, I have not had the privilege of wearing the uniform, but being on this committee, I wish I had. I'd like to hear a little bit more about the open science model that you were talking about. If you could elaborate, and specifically, what kind of recommendations rise to the level that you would go to bat to the Secretary of Defense to say, 1 hour is it, and we're not going to change that?
Well, it's kind of amazing that in the military model, we follow the civilian model almost exactly. I thought my doctors were different. They're no different. They're brought up in your culture, and your culture has some, I'm sorry for the generalizations, but I'm just going to say it. No one in your culture is necessarily rewarded and moved ahead because of team science. It's what you do as individuals in many ways. And the fact of the matter is that we have something like Bayh-Dole, passed in 1980, before we have the great analytical capability we have today, that gets in the way of the $1.3 billion that the United States military spent in research in traumatic brain injury and post-traumatic stress since 2007, that we can't, after a period of time, get those databases and look at those databases as a whole. The fact that we paid $50 million for the STAR studies and that data is being held up in 4 institutions because that's the way medicine works. If I had done what you're allowed to do, take government money and use it for private gain, okay, in the harboring of data sets and never releasing them or publishing the complete data sets with your work, they would have sent me to Leavenworth for what we call the long course. We have got to change the medical research model that we have today and find a way that we can make use of the unbelievable analytical power we have to look at the digits that are made up of it. The fact that we can't get DOD and VA to agree on a single electronic medical record? Come on. I mean, I literally showed up as Mr. Corelli, a 4-star general, with 5 inches of paper the second time. Because the first time I was told they could access my records, the doc looked at me and said, "Are you crazy?" The VA doc did, and sent me back home 50 miles to bring my medical records down so he could finish my, I mean, we have got to change the way we do medical research in this country. I believe we've got to follow the lead of the genomists, who out of the pure power of the fact that there is so much data that they have said, listen, we need a different model. We've got to share data because that's the only way we're going to take full advantage of what we've got here today. We've got to find a way to take all those different TBI research projects that have been done that are all little puzzle pieces out there and try to put them together in a way that we understand where we've got holes and where we don't have holes so we can understand the biology that we don't understand today. We are at the point of TBI where the only thing we have to diagnose mild and moderate traumatic brain injury is Glasgow coma? Jiminy Christmas. That's craziness. And why is it? Because it's a hard problem. And the only way you're going to get at the hard problems is large-scale collaborative medicine, where teams work together. It's not going to be having a chair at Harvard or Princeton or whatever solve these difficult problems, in my opinion. And it's not efficient, and you're seeing that in decreasing NIH budgets. I think we've got to change. And I included in there the open science principles that guide one mind. I think you've got the slides to talk about it.
Last question, Ellen Embry.
Thanks for coming. The question I have is, there isn't anything you said that I don't disagree, and in fact, I applaud your persuasiveness in convincing the commission to include some of your recommendations, because I think they are revolutionary, and given the fact that the military is downsizing and everything else, it makes sense. That said, if you say is true that it was dead on arrival, we are now in a situation where we have a 3-star leading 3 stars. We have I think, a task on this committee to try to come up with some useful recommendations within the structure that currently exists on how to preserve and promote capability to do the kind of readiness thing, 4-star notwithstanding. From a doctrinal perspective, as a leader in DOD, what does the leadership inside the military, health system, and elsewhere in the Pentagon need to do to build the infrastructure to sustain and maintain the skill sets that they built over the last decade. Because I think everything you said is true, but if we can't make that happen, then what's our alternative?
Well, I don't think there is an alternative inside the current system. I just don't see how you can make it work. I don't see how you can make it work. There are a lot of people who will say, well, we'll train with industry. You know, we'll send our doctors out and we'll get them the reps they need by having them be in major hospitals in major cities. But you can't do enough of that. You just can't do enough of it to make it happen. I think the best thing the committee could do is to take a look at what we did at MRMC and let's get the power of it coming from more than one direction. Let's you know, what the IOM says when it comes to medicine is listen to a heck of a lot more than 2 retired 4-stars, you know, and 2 senators, and you know the composition of our commission. You know, again, we suffered that problem that we got an hour with the folks, but then, you know, the Surgeon Generals went into their chiefs and said, these guys are all wet. We're gonna handle this. We're gonna handle it with military home medicine. We're gonna handle it with training with industry. We're gonna fix this. We're gonna track back, you know, the cases that we lost after the war. You know, we're gonna fix this. Well, they're not gonna fix it. They're not gonna fix it to the standard that has to happen. And I think it would be wonderful if you would add to the chorus and look at these numbers, add to the chorus of what our commission did. And when you take our commission, which I've given it very little credit, but it's probably had more of its recommendations put into an initial NDA than any other commission has ever had before. There's a lot of other recommendations we made. But if you added your voice to our voice, maybe, as we've been told, they're going to relook this thing next year. We could get some movement in the right direction.
Thank you. Before you leave, General Crowley, Kathy, you had something you wanted to add?
So apologize. Sorry, can I lean over you, Ellen? Apologize, but just, I think what you've described, if I can add an editorial comment, is something we've been talking about, which is the military to civilian is a living, breathing system. And that if you send your people to civilian systems that haven't learned the last lessons, they go back in 20 years behind. And then you start all over again. So until we get better and recognizing the fact that it is a living, breathing system and one influences the other and back and forth, you're really not going to see any change.
You know, I know you got to go, but I just got to say this. The comment about 4 guys in a dining facility making a determination on what to do, that to me is huge. And there's just got to be more of that. And not just 4 guys in a dining facility who've been up for 22 hours straight who make a decision on what to do. And God, I love you guys because you stopped me from writing a hell of a lot of letters. But somehow this system has got to really be looked at, and it's just not the military system. It's the system our doctors come out of. They're only parroting what they learn from you and they learn in medical school is how they get ahead of this business. And somehow, in my opinion, we have got to really step back and look at that and say, and I'm not talking about blowing up the whole system. I'm saying, is the system we have today, given the advancements we've made in other areas, just the advancements we've made in analytics, the ability to take all those MRI imagings that we're doing today and turn them over to people like Palantir and Asadi and other folks to see if they can find things that the radiologists can't see in those, is huge to the work that we're doing in traumatic brain injury. I just wish you would take a look at the entire system, from how we train people, how we advance people, first author, last author, the whole 9 yards, and say, is this really the best way to create the kind of total medical learning system that we need in the 21st century?
Well, General, let me speak for the committee in thanking you again. This was a stretch for you to get here, but it was really worth it from my point of view. I thank you for your clarity and your courage and your message, and I guarantee we've heard you and put this to use.
I'm sorry I'm such a blowhard, so to speak. I know of no other way to get your attention, and
you're a learner.
Please write to me if you want to complain of what I said.
Not at all. You're a learner and a teacher, and we learned from you today, and I'm really grateful. So thank you very, very much. Committee, our open session is finished. We'll be going into closed session. We ate into our break. We're going to take a 15-minute break. You've certainly earned it. So if we could be back in the room at 20 after, and we'll move on to our next session. And thank you again, General, for joining us.
Thank you.